Well, thank you very much, and welcome once again. Thank you for turning up. We have to get going because of time constraints, so we're going to wait for people who will be trickling in, but they can join us. So welcome to this session. It's on non-communicable diseases, and we've lined up some very good speakers for you. And we'll start with a talk from Professor Eugene Subni, who has just literally arrived from Cameroon. So thank you very much, Eugene, for coming in and happy to make your presentation when you've literally just come out of your plane. And Eugene is a professor of endocrinology, diabetes, University of Yaoundé, and he's done a lot of work on mechanistic understanding of diabetes in terms of its different phenotypes, and also very much linked to policy. He's been a vice president of the International Diabetes Federation and sat on several other committees in as far as diabetes is concerned. So it's a huge pleasure that Eugene is able to join us today. And am I making the presentation? Okay. And so he's basically just going to give us an Professor Nelson, thank you very much. I started stepping in your shoes and they were feeling a little heavy. So I'll not spoil the excitement and let you take over from me. Shall we start with an opening prayer?
We shall pray at the end. Ladies and gentlemen, I'm extremely sorry that I'm a few minutes late, but I hope you had a good rest and ready for today's discussions. So I'll not waste time. Our first presenter is no other than Professor Eugene Songwe. He is a professor of medicine and chair of endocrinology and diabetes at the University of Yaoundé in Cameroon. He is an expert in diabetes research, molecular medicine, and health policy, and has participated in many international meetings and consultations with WHO and IDF. As you must have seen in the program, he's going to talk about unique manifestations of diabetes in sub-Saharan Africa and the implications for diagnosis and management. Please, over to you.
Thank you very much, and good morning, everyone. And it's really a pleasure to be here. I would like to thank all the organizers, Moffat in particular, for getting me here. It's not very far, but there were some little issues, and I think it's for the good. So unfortunately, I've not been able to listen to all the exciting talks yesterday, but I hope this will not be boring compared to those of yesterday. And I wish anyway, you are always glad when you have the first talk of the day, people are still awake, they've just had their coffee. And because you will really need your coffee or your caffeine level to be high to follow what I have to say this morning, because it's about what can be considered as bizarre things in NCDs. It's about unique manifestations of diabetes in sub-Saharan Africa and their implication for diagnosis and management. I have no conflict of interest, and I would like to go through this topic by showing some few clinical presentations, then discussing pathophysiological characteristics from the viewpoint of the studies we've conducted concerning a few subtypes of diabetes, and then the implications for diagnosis and management, then we conclude. I would just like to show something that used to be called atypical diabetes, but we said in sub-Saharan Africa is just typical diabetes, typical maybe type 2 diabetes. In patients who are usually aged, they can be aged between 40 to 45 with some male predominance, family history of type 2 diabetes, overweight, lean or obese, everything is possible there, but with no markers of autoimmunity, but they come to the emergency room with ketosis or ketoacidosis. They are started on insulin, but very quickly they enter into prolonged remission, and this remission can last up to 12 years or more. In some cases, the traditional healer believes he has cured diabetes in those patients. And the remission might be also interrupted by few relapses. So it was called atypical diabetes, phasic insulin-dependent diabetes. And when we try to look at historical data, clearly the probability of remission was between 50 and 75%, and 17% of patients who enter remission would experience at least one episode of relapse within 3 years, and 90% within 10 years. And one patient being able to experience one or more multiple remissions. There are several descriptions of this. And I've even found in a library in the UK, an old paper dating back from the 60s, where in Nigeria and Ghana, they were described as patients with insulin dependence that may come and go. And this was just like the last sentence of the discussion of a paper describing diabetes in Africa, and saying that, okay, yes, we have lots of type 2, some type 1, but there are some patients in whom insulin dependence may come and go. That's how they described it. And it's now been shown in several continents, but predominantly in African origin populations with several names, some funny though, and some. Anyway, it's now known as ketosis-prone type 2 diabetes by WHO, and it is probably diabetes developing on a background of predisposition to type 2 diabetes and some precipitating factors that would lead to ketosis or ketoacidotic onset, just like a type 1. So what do we know about the pathophysiological characteristics of these type of diabetes? We studied about more than 100 people from sub-Saharan Africa, including those with diabetes and those with normal glucose tolerance. We did euglycemic hyperinsulinemic clamp. It's I would say it's not an easy test to undertake, especially when you do it in 2 steps. You spend about 4 hours studying the sensitivity to lipolysis of the patient, studying also insulin sensitivity in response to the infusion of glucose in a patient receiving supraphysiological dose of insulin. And you also test the ability, the hepatic or endogenous glucose production by using stable isotope. What we found was that glucose uptake, which is actually insulin sensitivity as classically measured, was lower in those with KPD compared with people without diabetes, but it was comparable to those with classical type 2 diabetes. Looking at endogenous glucose production using this stable isotope,
the endogenous glucose production was increased in those with that KPD, just like in type 2 and not like type 1. Looking now at insulin secretion on historical basis, those who would experience remission tended to have similarly suppressed insulin secretion at onset, but days after, 15 to 60 days after, and a year later, had significantly higher insulin secretion compared to those without remission. As you can see on the left panel, at presentation, no insulin secretion in response to glucose, and after, at follow-up, after people are well controlled and enter remission, they restore their ability in terms of insulin secretion to respond to glucose. This is another way of showing this. And using a test promoted by the Exeter team, which is urinary C-peptide over creatinine ratio, it was possible. This is a paper by J.C. Kate, who is probably in the room. It clearly shows that insulin secretion is comparable in those with classical type 2 as those with ketosis prone, and it's significantly different from those with type 1 diabetes. Why am I insisting on trying to see the difference with type 1? Is because they were initially called in the WHO classification type 1B, and clearly it's not a type 1, it's rather a type 2. Interestingly, when you use another molecule that can stimulate insulin secretion, arginine, that's an amino acid, in those even with suppressed insulin secretion in response to glucose. Here we have infused glucose, brought people up to a glucose level of almost 4 grams, 400 milligrams, or more than 20 millimoles, depending on which unit you use. And at that time, you add arginine. Within 5 minutes, they were all able to double their insulin secretion, meaning that they might not be responsive to glucose, but responsive to other secretagogues. It clearly shows that it's not a matter of destruction of beta cell, but something functional that might have happened. I will not insist on this. It was just to show that glucagon level was also as high as in type 2 diabetes. When you look at HLA alleles and haplotypes, they are comparable in type 2 compared to KPD patients. This was just 100 patients, about 100 patients of each in Cameroon and in France, of all of sub-Saharan African origin. So what could precipitate this is actually maybe some environmental factors. We thought of several things, and based on the superposition of the prevalence of antibodies against HHV8, the Kaposi sarcoma-associated virus, herpes virus, and KPD, we decided to look at this and found that one of the differences between classical type 2 and KPD was the prevalence of antibodies against HHV8. But in the background population, the prevalence is very high, it's above 20%. So what does that mean? We had the opportunity to work with people who are doing islet transplantation, so they had lots of islet that they were throwing away, and we tried to see whether HHV8 could infect pancreatic islet, human pancreatic islet, because it's a human virus, you cannot try it on an animal model, and surprisingly, it could infect pancreatic islet, but only beta cells, not the other cell types of pancreatic islet in suggesting that HHV8 reactivation could be amongst the factor precipitating the ketotic onset of these type 2 diabetes. Meaning that ketosis-prone type 2 diabetes has both features of type 1 and type 2 and mostly pathophysiological background of type 2 diabetes. Another insight into diabetes in sub-Saharan Africa came from a study that we conducted with my late friend Nabi Balde, our dear friend Nabi Balde, in more than 1,000 patients in Guinea and Cameroon. First of all, we found that in terms of prevalence of obesity, it was less than 15% in Guinea, while it was almost 35% in Cameroon for type 2 diabetic patients with otherwise similar characteristics. Meaning that in Africa, you would have some lean type 2 diabetes, predominantly lean type 2 diabetes, or predominantly overweight and obese type 2 diabetes, just as in Europe, depending exactly on which population you are studying. And Moffat has done a lot of work with his students and UDEEP, in the UDEEP study, comparing lean diabetes to non-lean type 2 diabetes. This is a slide that I borrowed from J.C. Kate. And clearly there's a significant proportion of Africans with type 2 diabetes who are young and lean. I will not insist too much on this. There are people who are better than me to talk about this in this room, but the idea is, finally, we have classical type 2 with ketotic onset. We have lean young patient with classical onset and clinical cause of type 2 diabetes in the same population. And when you look at insulin secretion and insulin sensitivity, they have both reduced insulin secretion and insulin resistance in these lean, young lean type 2 diabetes. Meaning that if you treat them like classical type 2 diabetes with weight loss and metformin, you might not be as effective as in other populations, and this needs to be studied in depth to better understand how to treat these specific phenotypes of diabetes in African origin populations. And indeed, there is an old paper from 1997 from Guillermo Perez, where they tried in people with KPD, glyburide versus diet alone in those who were in remission, and they clearly proved that with sulfonylurea, it was possible to prolong remission in KPD patients in the US, meaning that there is a window of opportunity in terms of thinking, I would say, out of the box. It's true that in the US in those days they didn't have metformin, but it was the opportunity to test glyburide and to show that clearly it prolongs remission. So we probably have a spectrum of, I would say, glucose abnormalities in sub-Saharan Africa, ranging from classical type 1 to classical type 2, with differences in age at onset, variable obesity rates, variable proportion of metabolic syndrome, of HLA associations, of autoantibodies association, of response to insulin, and response to other treatment, of C-peptide, of systemic inflammation. It is clearly an opportunity to go further, to go in depth in terms of personalized medicine in diabetes, personalized treatment with clear clue on pathophysiological mechanism, metabolic features of diabetes. I would like just to end by thanking a lot of people. There are people I didn't know how to classify them, whether they were Uganda, or UK, or other country, or even Namibia. So they were just classified as UK. There are people from all over the world who has, over the past almost 20 years, we have discussed and worked together to pull this little amount of evidence that I've just shown to say that there is clear evidence that diabetes is a a widely variable set of diseases in sub-Saharan African population with a similar characteristic, with one single characteristic is high glucose level. This is actually what Minkowski could measure. Thank you very much.
Thank you for a very stimulating presentation. Now, let me explain one thing. I see a set of chairs in front of us, and I was quickly invited to sit there with the speakers. And I gently declined because I realized that if I sit there, I can't see the slides. So that's why I'm not sitting there. Let's go to our second speaker, who is no other than Professor Eugene Chinyanda. As you realize, Eugene is fairly popular among, the name Eugene is fairly popular among the speakers this morning. Eugene Chinyanda is head of mental health at the MRC UVRI research unit in Uganda. He specializes in psychiatry, I'll skip that, and mental health integration into HIV care. He leads studies on psychiatric disorders in HIV/AIDS, infectious diseases, comorbidities, and mental health challenges among healthcare workers. And the subject for his presentation this morning is bridging the mental health treatment gap in Africa. So, Professor Chinyanda, you're most welcome to give us your presentation. And as they sort out, I realized on the program that you are given only 15 minutes. And I hope that was intentional, and you'll stick to 15 minutes. I beg your pardon?
Okay, do you realize that? No. Yeah, thank you very much, Professor Seonkambu, for that kind introduction. I'd like to thank the organizers of this meeting, especially the director, Professor Moffat, for having come up with this idea of this dissemination conference. I think in the unit we do a lot of good research, but we never used to have opportunities to share this, so thank you very much. So good morning, ladies and gentlemen. The title of my presentation is Infection plus Distress, Bridging the Mental Health Treatment Gap. As we heard from Professor Lutwama yesterday, Uganda sits on a belt where we have all these emerging viral diseases that are all the time coming up. So I would like to discuss 4 of these diseases and their mental health consequences. So in the last 4 decades, Africa and the world globally has been affected by major epidemics resulting from zoonotic virus diseases. The causes of these outbreaks are many and complex. They probably include climate change, increased population pressure, with man invading habitats previously the preserve of wildlife, globalization, especially global travel, civil conflicts that have resulted in mass displacement of people, especially in the Great Lakes region of Africa. So let us review the outbreak patterns of a few of these zoonotic diseases in the African context. So the first disease I want to look at is HIV pandemic. This can be traced back to 1959 in the DRC. Kinshasa. Okay. HIV to date has led to more than 35 million deaths. There are currently 39.9 million people who are infected, 65% in Africa. The other pandemic I want to talk about is the SARS-CoV-2, which started in Wuhan, China, and has infected 700 million people, killed 7 million, and we believe there are about 22 million people with active disease. The other virus I want to talk about is the Ebola virus, which was first reported in the DRC in 1979. There have been a number of outbreaks globally, the worst being in the 2014 West African outbreak, where we had 26,000 infected and 11,000 deaths. Uganda has had 8 outbreaks, with the 2 most recent being the 2022 outbreak in Mubende, where we had 164 infected and 55 deaths. The country is currently going through another outbreak, which started in January, and we've so far registered 14 cases and 4 deaths. The last virus I want to talk about is the Mpox virus, which was first identified in the 1970s, still in the DRC. We had a 2022 global outbreak, which involved more than 120 countries. This was due to the subtype Clade2, and we had 100,000 cases, 220 deaths. Then we also have had the current outbreak, which began at the end of last year, and it has so far involved 128 countries. This is due to Clade1b. It has so far involved 120,000 cases, 272 deaths. The situation in Uganda is that by the 11th of February this year, we are reporting 2,896 cases and 19 deaths. So these zoonotic virus disease outbreaks and epidemics are not only associated with physical morbidity and mortality, but also with psychological distress. And this psychological distress does not only involve the patients or survivors, but also caregivers, bereaved family members, orphans, community members who've suffered social and economic disruption as a result of the containment measures. You'll be hearing more about the experience of the Ebola survivors from our recently conducted Ebola plus CD study in a presentation that will be made by Dr. Ruamahe after break. Over the last 18 years, the mental health focus area of the MRC unit in Uganda, among many other research programs, has been involved in studying the psychiatric consequences of these zoonotic virus diseases, initially with a focus on HIV/AIDS, but we have now expanded to include Ebola and Mpox. Our research initially focused on documenting the epidemiology of psychiatric disorders and in developing and evaluating mental health intervention models in care platforms. More recently, our research in this area has expanded now to include development of a backbone that will support personalized psychiatric medicine in Africa, including evaluating biopsychosocial markers of diagnosis and treatment response, and evaluating AI-supported predictive models. In the next few slides, I'll highlight a few of these studies. In 2010, we undertook a DFID-funded study where we enrolled 680 adult persons living with HIV, attending care at 2 public healthcare facilities in Entebbe. And this slide shows the pattern of psychiatric disorders in these patients. The most prevalent disorder was major depressive disorder at 8.1. Then next was lifetime attempted suicide at 3.9, post-traumatic stress disorder at 1.6, generalized anxiety disorder at 0.8, and alcohol dependency at 0.7. We also did a study in 2015, which we undertook with funding from MRC DFID, which was a longitudinal study involving 1,339 youth living with HIV. Study participants were recruited from 5 public healthcare facilities in central and southwestern Uganda. And from this slide, you can see that 17.4% had at least one psychiatric disorder, and in 9.6% it was a behavioral disorder, either conduct disorder, oppositional defiant disorder, attention deficit hyperactivity disorder, while in 11.5% it was an emotional disorder, either an anxiety disorder or depression. In 2016, we undertook a cross-sectional study involving 471 respondents, 50 years and above, attending the MRC old age cohort in the GPC in Chamliwa. In this slide, we demonstrate that the older persons affected by HIV differentially had different major depressive disorder rates. We can see on the extreme, on your extreme right, we have the HIV positive who had a rate of depression of about 11%. We had those who were HIV negative but had lost a child to HIV, who had a rate of, having challenges with this. Had a rate of 9%. Then we have those who are HIV negative but had a child on ART who had a rate of 2.6. And we also had HIV positive but not affected who had a rate of 7.1. Probably some of these results, particularly the result on HIV negative and the child on ART, may have been affected because when you do the sub-analysis, the sample numbers become very small. Okay. So we recently conducted an MRC-funded study, the Ebola plus D study, where we undertook to develop and pilot a mental health intervention model in primary care in Mubende district. The Ebola plus D mental health intervention was aimed to address Ebola-associated medium and long-term psychological distress. Among the 45 Ebola survivors who had significant psychiatric disorder, we can see this is the pattern of the psychiatric illness that they had. Those who had major depression were 11%. Those who had generalized anxiety, 6.7%. Those who had post-traumatic stress disorder were 13.3%. And those who had high risk of suicidality. And as you'll be hearing from Dr. Rwamahe's presentation, unfortunately, some of this psychiatric morbidity is due to the way we handle these patients. I mean, you'll be hearing how sometimes the experience of being in the isolation and treatment units is very traumatic to these patients. In this slide, we show the characteristics of the persons with psychological distress who accessed the Ebola plus D mental health intervention. These included Ebola virus disease survivors who are 3.4%, suspected cases who are 3.2%, family members of Ebola survivors 7.1%, those who lost a loved one to Ebola were 8%, but the majority were other community members who had been affected in one way or another by the containment measure, by the general anxiety in the community as a result of having Ebola in their community. We also had some health workers in that study. There's a robust evidence for the effectiveness of both psychotherapeutic and antidepressant medications in the treatment of common mental disorders in HIV, which I'm using as an exemplifier of other zoonotic diseases. For example, my colleague, Professor Nachimuli Mpungu, has demonstrated that group support psychotherapy is effective in HIV in post-conflict northern Uganda. Also, our colleagues led by Dr. Chivanda in Zimbabwe have demonstrated the benefit of problem-solving therapy through the friendship bench in containing common mental disorders in HIV. But despite the availability of these evidence-based treatments, the uptake of mental health services in treatment care platforms in Africa has been slow. And this can be attributed to both contextual and health system barriers. In the case of HIV, some of the challenges that are experienced in the health system include the low recognition of mental health problems in health systems, with most people of African ancestry thinking of depression as either witchcraft or a spiritual problem. This low literacy is even observed among health workers. And as a result of this low literacy, there's low demand for formal mental health services. There's also a severe shortage of mental health professionals. In Uganda, a country of about 46 million people, we have only about less than 60 psychiatrists, most of whom are in urban centers. There's also a severe shortage of primary healthcare workers in public healthcare facilities. In a study which was done by Wegner, he observed that there were, at every public healthcare facility that was offering HIV care, a clinician had to attend to about 50 patients. In our recent Ebola plus D intervention, we also observed the same pattern of challenges. There was extremely limited number of mental health workers. In Mubende, a district of about 500,000 people, there were only 12 mental health workers. There was also extremely limited coverage. There was only one mental health department at the regional referral hospital and none in the other 42 public health care facility. There was also the issue of low mental health literacy in the community and the reluctance of public health care workers to engage in mental health care. One approach that has been recommended by the WHO to address this issue of lack of mental health services in primary health care has been to integrate mental health in existing service platforms. And one integration model that has received a lot of study is the collaborative care model, although there's still limited evidence in low and middle-income country settings. Patel and others in the Manas trial demonstrated the effectiveness of this collaborative stepped care model and the delivery of mental health care in India. In 2016, through a Senior Wellcome Trust Award, we developed research to develop and evaluate a collaborative care model based on the Manas trial in HIV care in Uganda, which we call the HIV plus D mental health intervention. The HIV plus D mental health intervention had 4 steps. The first step was offering psychoeducation to those who had significant depressive scores, and this step was provided by lay health workers. The second step was that for those who were symptomatic after 4 weeks, we offered a brief, structured psychotherapeutic intervention called behavior activation, which was also offered by lay health workers. Those who did not respond after 6 sessions of behavior activation, we prescribed antidepressants, and this was done by clinicians. And then we used the few mental health workers in the health system to provide referral support for those who did not respond to step through, or those who had high suicide rates, or who had very high base rates of depression. This slide shows 2 rows of figures. In the upper figure, we have the 4 steps of the HIV plus D mental health intervention, and in the lower row, we have the contextual and health system barriers. If we begin with the low mental health literacy, which is in the purple, we addressed low mental health literacy in the HIV plus D intervention by providing a health talk, which was provided by the lay health workers, and also provided psychoeducation to patients with significant psychological distress. To address the absence of mental health professionals, we provided the brief evidence-based treatment of behavior activation by lay health workers. To address the challenge of having no psychiatrists, we taught clinicians using the MH gap how to prescribe antidepressant medication. And to make effective use of the few mental health workers, we used them to provide referral support to this model. We subjected this model to a trial where we had 40 primary healthcare facilities randomized in the ratio of 1:1 to the HIV plus D intervention and enhanced usual care. Enhanced usual care in this case involved providing the clinicians with the depression scores and also training them in MH gap guidelines. Our primary outcome was depression severity scores at 3 months. We also had other mental health outcomes, such as the severity of anxiety symptoms. We had HIV care outcomes, such as ART adherence and also viral loads, and we also had health economics outcomes. On our primary outcomes, we observed that there was a mean PHQ-9 score at 3 months, which was lower in the HIV plus D arm than in the enhanced usual care arm, and this difference was statistically significant. We also observed that this intervention was effective against anxiety, which shows that this intervention had transdiagnostic effectiveness both against depression and anxiety. However, in that study, we observed that there was a differential response to treatment by different individuals. We, for example, found that 44% of the individuals in that trial responded to 1 session of psychoeducation, 43% remitted after receiving the behavior activation, while 13% had to be started on antidepressant medication. The selection of treatment in this trial was through the usual process, the usual clinical process of trial and error, and patients who eventually received antidepressant medication had to wait 16 weeks before we could get that treatment right. This long duration of waiting is not only distressing to the patient, but could lead to patient exhaustion, treatment disengagement, and premature dropout. So, is it possible to predict which treatment will work for a particular patient? This takes us into the realm of personalized psychiatric medicine. And to do this, you need two items. You need biopsychosocial markers, and you need precision treatment rules to guide patient identification and treatment allocation. So our research over the last 18 years provides us with a wealth of knowledge on potential biopsychosocial marker. On this slide, we show the demographic, social, and psychological and clinical factors that we have reported to be associated with depression in HIV. In a master's student project by Kenneth Musinguzi that was published in 2018, we also looked at other biomarkers. In this case, we looked at 3 peripheral proteins, that is CRP, IL-6, and TNF-alpha, And in that study, we noted that pro-inflammatory proteins IL-6 and TNF-alpha were associated with depression, while C-reactive protein was not associated with depression. We have expanded this work with my colleague, Dr. Andrew Buku, who is an immunologist with this unit, leading to the development of a pipeline based on the 80-plex human immune response panel, where I've recently completed analysis of the association between depression and 80 peripheral proteins using samples from the youth living with HIV cohort. We have also in a recent master's genetics project by Olga Tendo that employed a case control design where she looked at 280 adults, 139 with depression and 143 with non-depression. While there were no SNPs that attained statistical significance, probably because of the small sample size, at the recommended genome-wide threshold of 5 × 10 to the power negative 8, at the suggestive threshold of 1 × 10 to the power 6, we found 6 SNPs that showed promise. And these 6 SNPs have previously been associated with cognitive impairment, alcohol use, and bipolar affective disorder. To address the issue of inadequate sample size, I'm glad to report that my former student and my former master's and PhD student, Dr. Alan Kalunji, who won an Early Career Wellcome Trust Award in 2023, is currently undertaking the largest MDD-GWAS meta-analysis of people of African ancestry that will include 33 respondents from continental Africa. In a master's research project, Herbert Agassi undertook to develop and evaluate an AI-based predictive model for incidence of MDD using data from our adults living with HIV longitudinal cohort. In that study, he found that the best performing algorithms were extreme gradient boost, random forest, with the best predictors of incident depression being MDD polygenic risk score, social support, and study site. So as planned future work, we plan to continue characterizing the epidemiology of mental disorders in zoonotic virus disease, and I'm glad to report that we've had the opportunity to nest a mental health study in Dr. Jennifer Serwanga's WHO-funded study, which is right now ongoing at Entebbe Hospital. We're also continuing to develop and evaluate mental health treatment models for hard-to-reach communities affected by zoonotic virus disease outbreaks in sub-Saharan Africa. We have actually received requests for support from Congo, from Burundi, and even Rwanda. We also plan to continue evaluating potential biopsychosocial markers of depression treatment response, including genetic SNPs, peripheral blood proteins, metabolites, and messenger RNA. And we also plan to continue developing and evaluating predictive models for treatment response to depression and other common mental disorders. I would like to thank all the collaborators we've worked with over the last 18 years. I would also like to thank all the funders. Thank you very much.
Thank you, Eugene, for your presentation. Let's go to the last presentation in this session, last but not least. This is from Dr. Harriet Mpaire. She's a physician and epidemiologist at the same unit, MRC, UVRI, London School of Hygiene and Tropical Medicine, specialized in asthma and allergic diseases in African children. She investigates psychological and neuromechanisms of asthma prevalence. And she's a leading researcher in digital diagnostics for infectious diseases. Her presentation this morning is to address the question, is asthma in Africa the same as asthma in the Western world? And we'll discuss key concepts from their asthma work in this country. And so you're most welcome. I hope at the end we'll have some time to address 1 or 2 questions to each of these 3 panelists. So please keep your questions until she has completed her presentation.
Good morning, everyone. Thank you for coming to this session. I'm Harriet Mpaire, and I'm going to talk to you about asthma. The topic is asthma in Africa the same as asthma in the Western world? And I'm going to talk about the results from our studies here in Uganda. Asthma is the most common non-communicable disease in childhood, although it affects adults as well. It affects 262 million people globally and causes 450 deaths annually. The prevalence is on the increase in Africa and other low and middle income countries. And in those same areas, asthma is grossly underdiagnosed and undertreated. So the characteristics of asthma are chronic inflammation in the airways and narrowing of the small airways. And if you look on the first diagram, the first picture is of a normal airway, which is open and air goes in and out freely. The second one is an asthmatic airway before an attack, and the last one is an asthmatic airway during an attack. You can see the smooth muscles around the airways are tightened, and there is swelling and mucus production in the airway that blocks the airways, leading to difficulty in breathing, chest tightness, cough, and wheezing. And talking to these patients, they describe it as feeling like an elephant is sitting on their chest. So that's the kind of difficulty they have in breathing. So what causes asthma? We do not have a single direct cause for asthma known, but several risk factors have been identified, and these seem to be established early in life, although clinical symptoms may appear later in childhood or even adulthood. And the several factors that have been identified, some of them are context-specific, as I'll be showing you later in this presentation. And also, asthma presents in different subtypes, what we call phenotypes, depending on what is triggering the airway hyperresponsiveness and the chronic inflammation in the airways. So I'm going to talk about 3 studies that we've conducted here in Uganda, and all these studies have been conducted in Entebbe and Wakiso. Wakiso is a district that encircles Kampala, the capital, and that's where most of this work has been done. So the first study is a study on asthma among children. The main objective of this study was to identify risk factors for asthma in this setting. It was a case control study that we conducted between 2015 and 17. We enrolled 1,500 school children, ages 5 to 17 years, and 52 schools in Entebbe and the surrounding areas of Wakiso participated. One of the key findings from this study was that asthma risk was associated with the residents in early life. The picture shows the colors of a traffic light, showing that in green, children who were born in rural areas had the lowest risk of asthma, and if you take that as the baseline group, in orange, you find the children who were born in any town in Uganda, whether it's Entebbe, Masaka, Gulu. We asked if they were born in the town. The risk of asthma was 2 times higher compared to the rural-born children. And children who are born in the city, that is Kampala, you see in the red, they had a 3-fold increased risk of asthma compared to the rural-born children. And you remember that these children I enrolled these children from Entebbe, which is an urban area, but their asthma risk was related to where they were born, where they spent the mother's residence during pregnancy and in the first 5 years. What was interesting that if if a mother was pregnant while in Kampala and in the first year of life moved to the villages or rural area, the risk of asthma in that child remained high as that of in Kampala. And the same was true if a mother was pregnant in the village and later on the child moved into the urban areas in early life, they carried the lower risk in early life. So this suggests that whatever is causing the risk is mostly during pregnancy. That's the most critical period. So the other risk factor we found is that asthma was associated with urban, not only in urban, but also modern lifestyles. We looked deeper into the category of urban participants. We found that the asthma risk in green is the rural, low-educated children, and in red is children whose parents who were born in the city and whose parents had a high education and high socioeconomic status. You can see their risk of asthma is 7 times higher compared to the children born to mothers in the villages with a low education. So this suggests that not only is a risk in the urban area, but also there are lifestyle factors that are important. The children in the urban areas whose parents had a low education, their risk was slightly lower than those whose parents had a high education. So this is important for us to investigate what those lifestyle factors are. So the other observations was asthma was associated with allergic sensitization, as has been shown in high-income countries. For example, children with asthma were more likely to have positive skin prick tests. They were more likely to have elevated levels of exhaled nitric oxide. That's a measure of airway inflammation. And they were more likely to have allergen-specific IgE in their bloodstream. But the level of sensitization was lower compared to what has been observed in high-income countries, and I will explain to that later. We also worked with a mental health group at the unit and found that asthma was associated with anxiety disorders. Children with asthma were more likely to report generalized anxiety disorder. They were more likely to report panic disorders and social anxiety disorder. And what was also interesting is that there was an overlap of early life risk factors for both asthma and anxiety disorders. In other words, children with anxiety disorders and children with asthma all had the similarities in the risk of urban residence, high parental education, and allergies. So that was interesting, and we want to explore that further. We also found that asthma management in our population was inadequate. Of the 561 children with asthma, at enrollment, we found only 56% had ever been diagnosed with asthma. The rest, we diagnosed them during the course of the study, and only 18% had used inhaled salbutamol, and 7% had used inhaled corticosteroids in the last 12 months. These are the main treatments for asthma, and you can see the proportion that are using these are very few. And the result of that, we had poor asthma control. If you look in the pie charts, the majority of the participants had poorly controlled asthma at enrollment, meaning they had continuous asthma symptoms and difficulties throughout the day and throughout the year. And 13% had uncontrolled asthma, meaning repeated attacks and maybe symptoms at night. So the second study is a World Asthma Phenotype Study. The objective of this was to assess asthma inflammatory phenotypes in sputum, and it was conducted from 2018 to 2019, that is the fieldwork, in Uganda, Brazil, Ecuador, New Zealand, and UK. This study was headed by Professor Neil Pearce, who is in blue in that picture, and we enrolled 250 children and all youth in each country, ages 10 to 18 years. And what was important during the study, we conducted sputum induction to be able to define the different asthma inflammatory phenotypes. That involved inducing sputum using a specialized nebulizer, and then spinning the sputum and staining slides, and then using microscopy to be able to count the number of predominant immune cells, that's eosinophils and neutrophils, and using that classify the asthmatics, are they either allergic or non-allergic, eosinophilic. So what the main results were, that non-allergic asthma was the main phenotype in Uganda. If you look in blue, the column in blue, it shows we had 98 asthma cases with countable slides. And of these, 33% had allergic asthma, that is asthma that is associated with allergy, and 67% had non-allergic asthma. So I'm using non-allergic asthma interchangeably with non-eosinophilic asthma. The technical term is non-eosinophilic asthma, meaning the asthma could not be explained by eosinophilia in the airways. So the non-allergic asthma or non-eosinophilic asthma is important because it's the least studied and responds least effectively to asthma medications. So if we have more of these in our setting, that means we need to do more to understand it and to treat it better. The proportions were similar for Ecuador and Brazil, whereas for New Zealand and UK, it was 50-50, 50% allergic, 50% non-allergic. So asthma management, again, in this second study was poor, and with 66% of our children having severe asthma, and 16% having used inhaled corticosteroids, which is the mainstay of treatment. And more importantly, 40% were using corticosteroid tablets, and 54% were using salbutamol tablets. These tablets cause a lot of side effects, and in other settings, they are not used at all. Corticosteroid tablets are supposed to use in only very severe cases, and salbutamol tablets are not used elsewhere in the world. But we're using them here because they are cheaper. Ideally, we should be using inhalers. And the children explain to us that sometimes when they take these salbutamol tablets, for example, they don't go to school, not because of asthma, but because of the palpitations and the tremors. They are not able to write in school, so they stay home for 2 days or so. So our contribution towards better asthma management during this study was to educate patients, their parents and caregivers, and the general community during different days. We had refresher training for health workers in the participating hospitals in Entebbe and Kisubi in asthma management using the proper international treatment guidelines, and we supported the establishment of a dedicated asthma clinic at Kisubi Hospital that is still running to date. So the last study, which is currently ongoing, is a study on causes and mechanisms of non-atopic asthma, the CAMERA study. The objective of this study is to investigate the causes and mechanisms for non-atopic asthma now that we know that non-atopic asthma is the most important and in our setting, affecting 2 out of 3 children with asthma. And we're interested in finding what are the, if it's not allergens triggering the airway hyperresponsiveness and inflammation, what other mechanisms could it be? Could it be neuromechanisms? Could it be psychological stress? And so that study is ongoing in 4 countries, Uganda, Brazil, Ecuador, and New Zealand. And each, the case control study, and each center is going to enroll 160 adolescents. So the procedures, as we are currently conducting them, is we're using nasal lavage to assess asthma phenotypes. This time we're not doing sputum induction because in the previous study we showed nasal lavage, which is simpler, it works as well as sputum induction. And we are conducting cold and dry air challenges to assess neuromechanisms to see if those are the main triggers for the asthma in these participants. We're also conducting capsaicin challenges, again to assess neuropathways. And we're also collecting hair samples to assess for hair cortisol concentration as a measure of chronic exposure to chronic stress. So enrollment in Uganda is for 13 to 23-year-olds, and we started at the end of last month. So the question I started with is asthma in Africa the same as that in the Western world? Yes, but there are context-specific differences. For example, in Uganda, we show a clear stepwise increase in asthma risk depending on where the child was born, whether it was rural, town, or the city, whereas in the West, they have shown that the children born on farms have lower risk of asthma. In Uganda, we find that the asthma risk is higher among the urban rich. I'm calling them urban rich, whereas in the Western countries, asthma is more common among the urban poor. So what is going on in this setting? And we have shown that 70% of asthma in our setting is non-allergic type of asthma, whereas in the West, the proportion is 50-50%. And we've shown there is poor asthma management in our setting that leads to poor patient outcomes. So the call to action is really for further research to understand the causes and mechanisms of asthma, particularly non-allergic asthma, because it's the least understood type of asthma, so that we can develop better treatments, and also to improve patient outcomes through better asthma management. So under further research, we need to understand the causes and mechanisms for the airway hyperresponsiveness and chronic inflammation in order to develop better treatments, to identify the environmental and lifestyle causes or factors in our setting. And this is important that we do it now before we lose the urban-rural differences, because with modernization, even the poor areas, the rural areas are becoming more as the urban areas, and we'll miss that opportunity to see what differences exist there. And to investigate factors that lead to disease progression if you are to prevent them. So under improving patient outcomes, we want to educate patients, caregivers, health workers in asthma management, and advocacy to reduce the treatment costs, because one of the reasons we're not using inhalers was the high cost of these treatments, and ensure equitable access to quality care for asthma. And for us to do this, we need to work with the different stakeholders, because as researchers, we can't do all this. So I want to thank you for listening to me, the study participants and my colleagues, the collaborators, and these studies have been funded by the European Research Council and the Wellcome Trust. Thank you very much.
Okay. So, thank you very much, Harriet, for that wonderful presentation. These panelists have given us 20 minutes to address questions, receive comments, and suggestions. Please, let's use them efficiently. As she concluded her talk, Harriet, I thought in this room, there must be a number of people, not just a number, many people who are still trying to have children and more children, and living in the kind of environment which exposes, or which, according to our studies, people in the urban areas, asthma is more likely than those who are in the rural areas, if born in the rural areas. And I hope I got it right. So I had sympathy for you who are still trying to have children. And the question that came to mind is, what do we do for this kind of people so that their children are not like that? That is the first question. Anybody with questions or comments? Please just get up. Where are the microphones?
Thank you so much. Two questions from me, one to Eugene, Professor Eugene from Cameroon. That was a wonderful presentation. My question is, where did the idea of exploring association with HHSV/KS come from? Why did you consider exploring any other infections that are prevalent in Africa, malaria, etc.? Why in particular did you look out for HHSV? And then to you, Harriet, we have a growing concern of asthma as a one of the manifestations of long COVID. What do we currently know? I've actually seen a few people in the community whose children or who have developed asthma, and they actually think that it developed because of exposure to COVID vaccines, yet in reality it might actually be exposure to COVID-19. What do we know currently? Thank you so much.
So, just to be fair, let's now ask a question to the first speaker so that, each speaker has an opportunity to respond to some. Second speaker, sorry. Anybody? Okay.
Thank you. My name is Frank Kato. My question is to Professor Chinyanda. What have you done to avoid hallucination of the predictive models in the real world? I mean, have you compared the predictions of your model with validated measures of diagnosis for depression in the real world? Because at the end of the day, we don't want to have wrong predictions. Thank you.
So, please, go ahead.
Thank you. Thank you very much for your question, Professor Sewankambo. What do we do for people in urban areas who are planning to have children? The answer is we still don't know what factors in the urban areas are increasing the risk of asthma. So anything I say right now is going to be speculative. All we know is that it's linked with high education. So if the question is asked, what is it that the educated people do? How are we raising the children? What are we doing that increases the risk of asthma compared to our rural counterparts? And the answer is, I do not know. Anything I say will be very speculative. So that's the kind of research we need to do. And the best way to do such research is through birth cohorts. And it's been very difficult to get funding for this because the best would be to do a birth cohort and find out, because the early life from conception to delivery and in the first years of life are the most important. And that would be the best time to really investigate this and come to a conclusive answer. And it's been very challenging to get funding for birth cohorts. As you know, it's not easy. Yeah.
Thank you.
The second question was asthma following long COVID. Yes, this has been observed, not only here, but even in other countries. And it may be due to the scarring that happened, the infection and healing with scarring that could have happened in the airways. But at the moment, we treat the way we treat other asthma symptoms by using inhalers to relax the airways and also to have corticosteroids to reduce on the inflammation in the airways.
Eugene? First, Eugene.
Okay. So using is longitudinal data that we collected as part of our previous studies, where we had baseline characteristics and then followed up these people and we got incident cases. So we're able to test. Whether this model is. We compare the predictiveness of this model versus whether it's able to predict incident cases from actual clinical longitudinal studies that we have undertaken. Thank you.
Next.
Okay, thank you. The question was about HHV8. Why? I didn't tell the whole story. When we had these, the diabetes with ketotic onset, the other observation was that in the service, in the clinical department, we tended to have periods with the workload with newly diagnosed patients clearly higher than other periods. So we worked with people from the geography department to understand that there were like 3 to 4 periods in the year with more people developing or either having initial decompensation or relapses. And these corresponded to periods where there was a change in season. At the change of the season, there were higher levels. So we looked in the literature at viruses that were the most prevalent and the most frequently reactivated during these changes in seasons. And these were mostly among the herpes type viruses. And due to the high level of HHV8 antibodies prevalence in the population, we looked first at HHV8 and found that more than 80% of people with KPD had antibodies against HHV8. What about other pathogens? We are looking at other pathogens to understand whether these can be involved depending on the country, depending on the geographical site where you are. And hopefully we might find confirmation either for HHV8 elsewhere or find that depending on where you are, it can be another herpes virus or other type of viruses. So clearly it's a wide open area for additional research. Thank you.
Let's go for round two of comments and questions. The first one is, again, for Dr. Mpire. It's from an online participant. What is the role of genetics in asthma? Let's take 2 other questions for the other speakers before we respond. There's a hand at the front here. But if I don't see the people at the back, please stand up. These lights are always blinding to me.
Thank you very much, Chair and the presenters. I'm Dr. Jared Mutunja, and I'm from Ministry of Health, in charge of NCDs. My comment goes to Harriet's presentation. It was a very interesting presentation. I must say that in policy, in guidelines, we don't use salbutamol tablets for treatment of asthma. So I don't know those who are using tablets, where they get the guidance from. But the question is, only 18% of the children with asthma were using the the inhalers. But 35% of them, of all the children, were controlled, meaning that even those who are not using inhalers, some were controlled. What could have made their asthma controlled? Can some be controlled without any treatment? Because if they are taking salbutamol tablets, it's as good as not on any treatment. Thank you.
Thank you. Let's take 2 questions for each of the Eugene.
Thank you, Chair. This is Dr. Roland Chihemba. My question goes to Dr. Anne Empire, and it's to do with post-trial care. I'm glad that you established or you ensure that there's a continuity of anathema clinic at Chisuyu Hospital, but I understand this is a private hospital. Wouldn't it have been better if this clinic was established at Entebbe Regional Referral Hospital, where, you know, the participants will receive continuity care from a facility where they will not be paying? Thank you.
Thank you.
Thank you so much, the presenters. My question goes to Professor Eugene Chinyanda. Is it necessary, and if it's necessary, is there a special program for the children and adolescents with the HIV that have been diagnosed with some of these mental conditions? Do they have like a very special program that caters for only them, or their interventions are general, like for other people?
Thank you. No diabetes question or comment?
Thank you very much. My name is Rogers Mukasa, laboratory technologist under the NCD theme. I have a question to Professor Eugene Songwi. So about the unique manifestation of diabetes, was there any probably aspect of trying to consider the carbohydrate intake in these individuals prior to this? Because I've read some literature that was trying to describe a relationship between prolonged reduced carbohydrate intake in these lean individuals, which could actually induce ketosis. Thank you.
Sorry, please. You said prolonged. I didn't get you about carbohydrate.
Prolonged reduced carbohydrate intake.
Okay. Thank you.
So go ahead. I'm going to answer the address the question.
We were not able to find a relation between diet and ketosis-prone type 2 diabetes. And we tried, even in terms of treatment, several options of diet, including the very low-calorie diet. And clearly, there's no relation between the type of treatment, apart from giving insulin that will promote remission, or with which one you will have the relapses. That study from 1997 in the US showed that with sulfonylurea you could prolong remission, but the observation is actually that whichever treatment you give, it tends to promote compliance to treatment, and people would have less often relapses. So whether it's reduced carbohydrate that promotes ketosis, I don't know, but we've not observed it.
Next.
Yes, there was a question on is there any treatment for youth living with HIV who have psychiatric problems? The guidelines which were released in 2022 have provision for that, but I mean, treating children requires special skills, and the personnel for treating them is, I do not have the personnel for treating, people don't have those skills for treating these children. So there's still a big gap in that area, because addressing adult mental health problems is probably easier than that of addressing mental health problems even in the youth, because it requires additional training. So it's a bigger challenge. While the guidelines have this provision, I don't think it's being implemented. We've tried to raise funding to come up with briefer treatments, but have not yet been successful in getting funding to do this work. Thank you.
There was a question on the role of genetics in asthma. Clearly, there is a degree of heritability in asthma because most studies have shown that parents with asthma, their children are more likely to have asthma. But the numerous GY studies that have been conducted have not yielded very clear direction of what the areas are. And the 18% were using inhalers and 35% were controlled, so there's a discrepancy. It's because we enrolled these children from schools and some of them had very mild asthma. And so for those with mild asthma, they were able to control their asthma with an occasional prednisolone tablets and salbutamol tablets because the asthma was already mild. So we had a whole range of asthmatics, yes. And these tablets, the salbutamol tablets and prednisolone tablets, they buy them over the counter from the different drug shops and pharmacies, yes. And they use very high doses, really. And why did we establish the clinic in Kisui? We did not establish, we supported them. We trained both the health workers in Kisui and Entebbe hospitals in the proper treatment guidelines. But Entebbe was not able to set up the clinic because we didn't have funding to set up the clinic. It was the hospitals to set up the clinics. Kisui was able to do that because it's a private facility. So we supported them with the treatment protocols, with the training, and everything we could to help them set up the clinic. So the hospitals set it up themselves. We only offered support. But in terms of training, we trained both Entebbe Hospital and Kisui Hospital. And for the children who, when we're referring, because we offer these children the first dose of inhalers and refer them for further management, we ask them that there are only 2 clinics in the country. There is one in Kisui, if you can afford it, it's a private hospital, and there is one in Mulago Hospital. So those who can't afford Kisui, they have to move all the way to Mulago Hospital for the only other asthma clinic in the country. Thank you.
Thank you very much. Thank you very much. We have 1 minute to end the session. Let me use that minute by allotting Moffat, who is, I believe, still the head of the NCD subunit, if I call it that, at the MRC UVRI London School Research Unit. After these presentations, what message do you want to deliver to this audience? As you come up to give your message, let me tell you a story. Last evening, I read on my phone a report from CNN. A 4-year-old child in Wisconsin who called the police, who called the cops, because his mother had eaten his ice cream. He called the police, and the cops did show up. You can imagine what went on after that. But the important question is ice cream. We don't eat a lot of ice cream here, but suddenly it is on the increase. Professor Eugene, diabetes, is this important or not before Moffat comes in?
When you ask the question about ice cream, my answer will depend on if you would like to offer me ice cream or just to say a general statement for them not to get the ice cream and let me have it all. No. Basically, in terms of dietary habits, we are experiencing a transition, and the problem of the adaptation to this transition is more about physical activity and portion sizes. You were talking about the US. I gave a talk there, and I was I spent minutes talking about commuting physical activity. And at the end, one person asked me, but what is commuting physical activity? It was actually, I would say, an Afro-European term, because that's where people can do physical activity, walking or cycling to work, while in the US is something that is completely bizarre to them. So talking about commuting physical activity was just like, I don't know what I was talking about. Just to say that let people eat what they have in their environment and exercise as they would normally exercise in an environment where those things are produced. If we produce starch, carbohydrate from starch, it was done by farmers who used to trek kilometers to get those carbohydrates. We cannot continue to eat the same carbohydrates while driving our cars or going on motorbikes. That's what I would say about ice cream or something else. Yeah.
Don't throw away the opportunity.
So, I think what I can say is that the NCD theme, this area, is relatively new for us as a unit in terms of an area of research. So it's good that we're seeing things grow, but at the same time, we also need to make sure that the observations that we make, we interpret them in a way that they are give out useful information. But already I think you can see that there are pieces of information which are very clear and important coming out. So for example, the differential manifestation of these conditions within the context of the environment that we live in. As Harriet, as Eugene, both Eugenes actually articulated. So I think that message is very important. It emphasizes the fact that we have to study these conditions within the context of the settings that we live in. I think it's also important to appreciate the differences, but at the same time, comparative studies. So for example, Harriet was saying in the UK or in high-income countries, asthma is much more predominant in low socioeconomic settings, whereas here it's higher in people that are educated, that earn more money. Why is that the case? My feeling is that as the economies transition, so in Uganda, if you are educated, if you are you have a bit of money, you want to spend that money on things that are not necessarily healthy. So you'll take your kiddies to Kentucky Fried Chicken as a treat. And whereas in the UK, if you are educated, if you have money, you go for organic food. So you can see, I mean, the trend was the same there, but it's reversed. That, you know, money means you can live more healthily, whereas within the context of Uganda and other African countries at the moment, if you have money, you want to show that by not doing exercise, essentially using motor vehicles or wherever you go, but at the same time you use it to eat junk food, because that's what affluence is. So unless so you can be educated but lacking health literacy. So it's important to bring in those contexts and hopefully interpret our results in a way that they can be much more meaningful and the interventions hopefully much more effective. I don't know whether I've answered your question or not, but it's a new area and we're glad that we're contributing to the evidence and that will continue to grow.
Thank you. Please join me to thank our speakers for this morning. I think it is time for a break, and you are going to get the marching instructions from me.
Yes.
Another Eugene.
Another Eugene, yeah.
Thank you so much, Professor Swankambo, and thank you so much, our speakers, for the excellent session that we've had this morning. So we are going for a tea break, and then after that, we'll have 3 breakout sessions. The viral pathogen sessions will remain here in this room, the Victoria Ballroom. The vaccines session will be in the Shina Hall. It's on the ground floor. So when you get out of this room, the stairs on your right, then turn right again, along corridor downstairs, the Victoria Ballroom, the Shina Hall is down there. And then the NCD disease theme and session will also happen down in the Mirror Hall. So let's be there at 10:50. Use about 15 minutes for the tea and 10 minutes to walk to those places. Thank you so much. See you then.
Hello, everyone. We should actually get started. It's already 11. So I need all the speakers up front, please. All the speakers, could you please come to the podium? All the speakers, please. You are. Eh? They're gracious. And
So, Prof, how are things going?
things are tough.
You go sawa. Now, Gen Z.
Okay, let's just get it correct. Eh?
So I guess we shall come to the podium.
Yeah, I think so. Jennifer is somewhere taking tea, but she's around. I think what we do, if you can allow us to sit down, then we can come here for like this. Yeah. Let's sit down.
Is that okay?
Will be empty.
It's okay. Maybe we can sit there first, and then we can go and sit down.
No.
Is that okay?
Jennifer is here.
Okay, Jennifer.
That's what she was thinking, but we're like,
Now they're saying they want to sit this way so that they can sit themselves. Yeah.
Then during the question, we can come back.
We are all.
Yeah, we're all here. Yes.
I'm not sure my talk is loaded. That's the only
We are loading. What is the IT?
But we have it also on the memory stick.
IT.
I saw your name.
So it should be okay. I'll give you that back.
Okay, so we can do this. But in front of me, I'm like,
I don't have your virus. I had my laptop.
I'll introduce out, yeah.
that's fine. We shall introduce ourselves. Yes.
Okay. So colleagues, we are all ready. All the speakers are here. Anna, don't go back. Just get ready. So I will let each speaker introduce themselves, and then we shall get on to the talk. Anna, please. The slides are ready to go? So you're good otherwise?
Yes.
Okay, just go ahead.
Good morning. Thank you. My name is Anne Kapata. I'm a research fellow at the MRC, Uganda Virus Research Institute, and the London School of Hygiene and Tropical Medicine. I completed my PhD in 2022, and here I looked at the different characteristics of the transmitted founder viruses, and that is what I'll be sharing about. I'm hoping that the slides will be loading in a minute. And I have no stories like Elizabeth to tell you. So just bear with the silence as the slides load.
So that's why I'm sharing. Okay, you will just keep pressing next. You keep breaking next. Yeah.
Okay, thank you. Just to remind you that this is Ann Kapata, and I will be presenting some of my PhD work, but also work from other colleagues or young scientists who are present here, some of whom are master students who have completed and have since enrolled for their PhDs. So I will be taking us through the different characteristics of the transmitted HIV-1 strains and their sensitivity to neutralizing antibodies. Yesterday, there was a good, all the talks yesterday actually did hint on the fact that the biggest burden of HIV, even when it's globally, the major concern is in the sub-Saharan Africa. And actually, one of the presenters mentioned that this is our burden because in the Eastern Southern Africa, we have over 20 million people who are infected with HIV. And of note is the fact that in 2023, there was over 1.3 million people that were newly infected. And the other greatest burden is the fact that globally there's HIV diversity, meaning there are several subtypes that are country specific, and this is a major obstacle to vaccine development. Researchers have hinted on the fact that if we are to have vaccines, we may need to employ the ones that are subtype specific, given the fact that there's a lot of diversity of the HIV virus. And for us to be able to even do that, we need to do research into our region and be able to illuminate the virus's behavior in our country. And that's what I will be doing. So what is the transmitted founder virus? In a chronic patient, we have what we call several variants that we have termed the quasi-species because there are several. But because of the bottleneck, which includes cellular restrictions, some of these bottlenecks are antiviral restrictions, where you have the interferons that should be playing a part at preventing the virus from crossing the mucosal barrier. We have things that, we have dendritic cells that should be playing a part to prevent the virus from infecting the next individual. But to show that this bottleneck is not efficient, one or two variants cross the mucosal barrier, and that virus that crosses the mucosal barrier is what we term as the transmitted founder virus. So that means that this transmitted founder virus carries the genetic footprint that allows it be able to infect the new host amongst the many that didn't cross the mucosal barrier. So it's then important that we look at what is it that is special about these transmitted founder viruses that allows them cross the mucosa and be able to establish infection. So we should be able to identify the vulnerable parts of this virus if we are to make a vaccine and any other prevention strategies like the ART. So studies have been done that have looked at the different characteristics that make up that transmitted founder virus. And most of them agree or agreed in earlier studies that most of the transmitted founder viruses use the CCR5 as their co-receptor to enter the CD4 cells and infect them. But yesterday we had Professor Pontiano mention that when it came to the studies he did earlier, he showed that our viruses in Uganda were switching quicker from the CCR5 to the CXR4. But generally in other subtypes, majorly in the Europe and all that, they all use or prefer to use the CCR5. What else was found out about the transmitted founder viruses was that they had shorter and they were less glycosylated. Glycosylation is just the ability of this virus to coat itself with carbohydrates or glycans that make it then escape from being recognized by the immune system. So this transmitted founder is less glycosylated, especially in its envelope, according to the several studies that have been done. These studies also showed that most of the transmitted founder viruses were sensitive to the antibodies that neutralize them. And also the other characteristic that has been mentioned is that when you look at the transmitted founder virus, it's replicating faster when compared to the virus that failed to cross the barrier.
Sorry, colleagues, I've been informed that guys on the online cannot hear. So we'll wait a bit as the ICT sorts this out. Sorry about that, Anne.
It is.
Just a minute. Close. So what's going to happen is, I'm going to share my. Good morning once again. Sorry for the inconveniences. So what's going to happen is, I'm going to put all the presentations for all the people going to present, and I assist the people downstairs. Hope that's fine. I hope you find your way around your opening your presentations. Is that okay?
Say what?
It's not clear.
What did you say? You're going to put them where?
Like, just a minute.
So there were challenges with some of the online participants locating their breakout rooms.
Breakout
yes, so
sessions.
including this one. So it is being fixed at the moment.
Okay.
Yeah. It's what she's fixing.
Share my screen, so everyone will find their presentation. Open it, it will be able to work.
Like they're on the desktop.
They are all open here.
Oh,
Yeah.
So when I finish, I'll
I'm
close
going
and the
down.
next person will come.
Yes.
Okay. Okay.
Yes, you can. Yes, that's fine.
Okay.
Okay, let me just make this small.
Can you remove those things which are like?
Let me just put them down.
I go on. Okay. Sorry about the online audience, but unfortunately I will not be repeating what I said. But you're free to ask the questions and say, what was slide 1 about? Yes, so I was mentioning the different... Okay. Yeah, so I was mentioning the different characteristics that have been studied when it regards to the transmitted founder viruses. And I was at the point where I was saying they are faster at replicating. I can see them.
How are you? Okay. You come. Okay. Okay.
Just ask the online audience to confirm.
Now we share. Which one was it? This one, eh?
They just come.
No, we're having. You get it?
Yeah, yeah. The audio, you're right. Join with the audio.
It's okay now?
Okay, so can the online audience just confirm that they can hear me with a message? Because I don't want them to miss. I continue. Yeah, so I was saying that the transmitted founder virus, according to many studies, has been shown to replicate higher and then also is resistant to the interferon. Interferons are the first line of defense at the mucosal. So if you're to cross, it means you were resistant. So most of the transmitted founder viruses are resistant to interferon. But however, all these studies have been done majorly among subtype B and C. And like I mentioned previously, we need to look into different subtypes and find out if those characteristics still hold.
Try and convince you can do this. So a few years ago now, Ben Barber from the NIH
Are you hearing that? Okay. So sorry, but I hope the online audience is hearing, because it looks like the volume here is for another breakout session. But either way, I'm going to continue. Sorry. He says hold on. He says hold on. Yes, so I was saying that most of these studies have been carried out among the subtypes B and Cs.
Hello, colleagues. I'm sure all of you who are here are very interested in viruses. So I've been asked to keep as excited a bit as we go on. Now, in Uganda, those who are interested in viruses, which area in Uganda do we see in dengue? The dengue virus. Yes. Any dengue in Uganda? And what of chikungunya? What of chikungunya? Is there a microphone so that we can keep ourselves engaged? Any microphone? And if there's also somebody from Tanzania, they can give us a sense. So we started with dengue. So in Uganda?
There's somebody who has just done
Yes.
very good work on chikungunya.
Yes. So we keep ourselves busy.
And the nyong.
Yes. So tell us, dengue, you are from Uganda. Just introduce yourself and say something about dengue, if you have been working on dengue.
Thank you. I'm Doris Nyamwaya. I've been working on chikungunya.
Okay, talk to us about chikungunya a bit.
Yes, so we did surveillance for chikungunya among febrile patients visiting various hospitals in Uganda. And we were not able to pick any chikungunya infection among those patients, but we escalated to do PCR for onyong-nyong, which is closely related to chikungunya, and we are able to detect onyong-nyong. So from our findings, we see that the burden of alpha viruses is more for onyong-nyong rather than chikungunya in Uganda.
Okay, interesting. In Kenya, for example?
Well, I can comment about Kenya.
Yes, okay, go ahead.
Because my PhD was actually doing surveillance for chikungunya in Kenya, in coastal Kenya. And we found that there was unrecognized 12% burden among febrile children visiting dispensaries. And it was a common cause of neurological disease among children who were admitted. And again, in some unpublished work, we were able to find that chikungunya is vertically transmitted. Again, part of my work, one of the most important results is that I was able to detect recurrent infections. The dogma is once you're infected with chikungunya, you get a long-lasting immunity. But from my longitudinal study, I was able to follow up children who were reinfected, and that is that informs on vaccine development, because the one that is available now is a single-shot vaccine.
Great, thank you. Now, we are ready to go? Thank you so much.
Thank you. I don't know. Someone is controlling the cursor, actually, not me. Okay. Yes, the transmitted founder viruses. I hope you remember where we started, because for sure I will not go back, but I'll let you know that the transmitted founder virus is that virus that crosses the mucosal barrier in spite of the many interferons and many barriers that should stop HIV from entering CD4 cells. It still crosses, and that virus that crosses is what we term the transmitted founder virus. And before the interruption, I had mentioned the different characteristics of the transmitted founder virus, and I had said that most of these studies were done mainly in HIV subtype B and C, but yet Uganda is predominated by subtypes A and D. So we had to look and see what was happening in our subtypes. So what did we find? So we found that among the samples we dealt with, we were able to go and do single genome amplifications, and we were able to identify the transmitted founder viruses among our subtypes. And what we found was that there was a high frequency of unique recombinant forms between the subtype A and D, meaning that A and D were combining to form A1D recombinants. They are unique because they were unique to our our population. But what was of note was the fact that the recombination was not random. It was happening majorly in the envelope gene. And even within the envelope, we see that it was within the signal peptide right there, as well as the GP41 transmembrane domain. And then what we have to say about this is this then causes a challenge if we are to design a vaccine, given that most vaccines are designed based on the envelope gene. So if the envelope gene is recombining this systematically, it means we need to rethink. So we went on to look at the ability to replicate. And for the ability to replicate, we did what we call the GAG-POL chimeras, where we got the transmitted founder GAG-POL gene, inserted it into the NL4.3, which is available, lab-adapted available backbone, and then we are able to infect the TRU93 T cells. And when these are infected, they produce what we call virus stock. So they produce the viruses, which we were able then to titer using the TZMBL cells and to infect the GXR cells at a particular multiplicity of infection. And from that, we were able to then have a value which we correlated to ability to replicate of these viruses. And what we found was the recombinants were replicating the highest, followed by the subtype D and then subtype A. Previous studies by Professor Pontiano had shown that because at that time in the, 90s or 2000s, when Pontiano did work on different subtypes and their progression to disease, he had showed that the subtype D were progressing faster than the subtype A. So this then went to correlate with the fact that in vitro, the ability to replicate was also correlated to the subtype you had. So if you had an A1D recombinant, then your virus replicates quicker, and then lowest if you had a pure subtype A. So we went on to look at the protein changes that happen in the GAG-P6 region, because studies had showed that the GAG-P6 was very instrumental when it came to the polypeptide processing of the virus. And what we found out was when we looked at the difference at the low replicators versus the high replicators, we found that for the low replicators, they preferred to have a proline at a particular position along the GAG-P6, while the high replicators had a leucine. So this showed us that this could be the reason why some viruses are highly replicating and some are low replicating. And this plays an important role when it comes to how efficient the GAG polyprotein is processed. With that information, we then wanted to dig into the envelope gene where the recombination was happening. So we did what we call a signature analysis using the available online tools like the Entropy and GeneSeq, which are available at the LANEL database. And this is because we did the envelope because we know that the envelope gene is a primary target for most vaccines. So we wanted to find out what was happening in the envelope gene. And most studies, like I've said again, that have looked at signatures have looked at subtypes B and C, and they found that there were specific signatures that these viruses were carrying, especially the histidine at position 12. So with the limited data in our subtypes, we then delved into signature analysis to look at what our envelope genes of the transmitted viruses look like. And what did we find? So we find that, or what we did here was we looked at the different subtypes, A alone, the D alone, and the AD recombinant alone. And we compared these with chronic sequences, which are online. So we went into the online database and pulled out sequences all the way from 1986, when the virus had just become an issue. So we compared those sequences within the same subtype to the currently circulating viruses. So we would compare the transmitted founder viruses of subtype A with the historical viruses of the same subtype to find out what was unique about the transmitted virus. And here we did find, I don't know whether you can follow my cursor, but we found many significant signatures, especially for the subtype A viruses. And of note is, for example, if you look at my cursor, okay, at position 22 of the envelope, which is, I think, the signal peptide, we find that the transmitted founder has a leucine, but also there's a methionine and a tryptophan, which are coming up to be used at that position 22. And then when you compare this to the historical viruses, these were preferring to use a leucine. And this was significant across the different positions for subtype A. But of note is that these positions, while S22 is the signal peptide, from position 416 all the way to 477, these are CD4 binding sites for the vaccine. So we see that the transmitted founder has several amino acids that it's using at those positions, while the historical viruses seem to be maintaining one amino acid at a position. And we did that for subtype A1D as well as the D. And we do find significant positions for the A1D, although the A1Ds we had in this study were quite few, and work is ongoing to just add on more A1D recombinants. We went on to then look at the co-receptor usage. And like I said yesterday, Professor Pontiano did say they did studies in the 2000s and found that our subtypes A and D were switching very quickly from the CCR5 to the CXR4. And we know that it's important because the entry of the transmitted founder into the cells requires that there's an interaction between the virus envelope glycoprotein, the CD4 receptor, as well as what we call the co-receptor, which is either the CCR5 or the CXR4. But like I said previously, most studies have shown that transmitted founder viruses prefer to use the CCR5 receptor during early infection and later switch when the person has become chronically infected. And also knowing that studies show that I think there was a clinical trial that allowed the use of maraviroc as an antagonist to prevent HIV entry into the cells among the many ARTs we do have. So we do have ARTs that specifically target the receptors or the co-receptors to block the entry of the virus at that point. And the one that has been FDA approved is the maraviroc, but yesterday I was reading studies and they said even this didn't go very far because the virus is switching. So we went on to look at how do our transmitted viruses, which receptors are they using? And to do this, we first used the online tool that they call the Geno2Pheno, I think version 3.4. And what we found was that 70% of the viruses were using R5 and 30% were using X4. That was when you used the online tool. But we went to the lab to then, to confirm this in the lab. So we used what we call the ghost cells that carry the different co-receptors on them. And then you're able to then grow the viruses and find out your transmitted viruses, what are they using as their co-receptor. And what we found was that our transmitted founder viruses were using both the CCR5 as well as using CXR4. Of note is to know that these viruses we are talking about as transmitted founder viruses were viruses we caught from a cohort that was part of the International AIDS Vaccine Initiative, where they would follow up the negative participant until they seroconvert. So these were quite early as less than 90 days post-infection. So it means as early as 90 days after infection, the virus in our subtypes is using both the CCR5 as well as the X4. The legend might not be clear, but for those that have sharp eyes, the red is corresponding to the CCR5. Each of the dot is a virus, while the blue or green is corresponding to the viruses that are using both. If we can count these, it looks like it's half-half. Half of the viruses were using pure CCR5, while the other half were preferring to use the X4R5. But of note was the 3 in purple, 3 viruses of the transmitted founder in our population that went to use an alternative receptor that we call the CXCR6. So among the many co-receptors we do have, the transmitted founder virus was using an alternative receptor that we call the R6. And this is usually for the NK cells when you read literature, and the T cells. So what is our take home here is we are seeing that our viruses are using both the X4 and the R5 for entry. So we went on to then grow these viruses in the presence of the antagonist, which is the Miraviroc, as well as the AMD 310. But yesterday night, as I was reading, the 310 didn't make it as an approved antagonist. But however, we did grow our viruses in the presence of both. And what we find is even at the highest concentration of the antagonist, our transmitted viruses were growing, meaning that our transmitted viruses are resistant to both the CCR5 and the CXX4 antagonist, which is Miraviroc, as well as the AMD 310. So lastly, we looked at how sensitive are these viruses when it comes to broadly neutralizing antibodies. So to do this, we had 239 pseudoviruses globally that were shipped to Uganda virus, and these were split into historical for the earlier viruses and contemporary. And what we see majorly for the Ugandan cohort, they were looking at the fusion peptide-based broadly neutralizing antibodies. The map here just goes to show that the red means that virus is very sensitive to the fusion peptide broadly neutralizing antibody. Then the yellow or brown is intermediate, and yellow means you really have low sensitivity, and gray means you're resistant. So when we look at our left graph here of the different fusion peptides that the Ugandan site was investigating, we see that there's a downtrend. But generally, we see that the historical viruses have some little ability to neutralize the fusion peptides when it comes, when compared to the contemporaries. So we see that there's a little bit of red there in the historical, but for the contemporary, which is just next year, we see that there's low sensitivity as well as a lot of resistance when it comes to the fusion broadly neutralizing antibodies. However, they did run the fusion along some controls, and the controls were the CD4 binding site antibodies, the common PG151, and VRC01. These are still okay. When it comes to the historical, we see that the historical viruses were being neutralized by these CD4 broadly neutralizing antibodies when compared to their counterparts of the contemporary. So this goes to show that, first of all, the fusion peptide broadly neutralizing antibodies are not as good for our population, but generally there's a downward trend where the historicals have a little bit of ability to neutralize to be neutralized by the antibodies, while the contemporaries, which we are calling the transmitter founder, are resistant. So all that work I've been talking about was done using the Sanger sequencing platform, but with technology advancement, we went on to explore or to transition to the Oxford Nanopower for identification of the TF. And here is because the Sanger is the gold standard, and it accurately identifies the transmitted founder virus. However, it's costly, and there's a low throughput. There are few samples you can work on at a particular time. So then the Oxford Nanopower offers a scalable, alternative. However, it wasn't yet validated for our population. So this was then validated by one of the students, and he looked at the ability of the Oxford nanopower to identify transmitted founder viruses. And what he found in blue of this phylogenetic tree were the sequences from the Oxford nanopower, and in black were the ones from Sangha. These were clustering together, showing that the ONT has promise as an alternative for us to identify transmitted founder viruses. And of note was the highest, there was a lot of similarity when you went down to look at the different amino acids of the of the sequences of the ONT versus the Sangha. This was as high as 99.7%. So after all these many words, what are we taking home? We are taking home that there's a high rate of intersubtype recombinants in our population. And this is not unexpected, given that we have two subtypes that co-circulate in our population, the A and D. So these are always going to recombine and give us the unique recombinant A1D. And then we are seeing that the transmitted founder viruses have distinct amino acid signatures. So if we are to make vaccines, the immunologists should be looking into these signatures as they are making the vaccines or the therapeutics. And of note is that if ever the antagonists were to be brought into this country, these wouldn't work. So we need adjustments in the ART regimens when it comes to the antagonists. Then for the broadly neutralizing antibodies, we have seen that there's a downward trend. These are not working well, so we need to design new broadly neutralizing antibodies with the transmitter founder virus in mind. And then lastly, the ONT is showing promise as an alternative to Sangha sequencing. Just to acknowledge the study participants, the mentors under which this work has been done, Professor Pontiano, Dr. Jennifer, and Dr. Sheila, then the different young scientists that have contributed some of the results that I've shown here. Thank you for listening.
Thank you so much. And we move on to the next. Please keep your questions up to the end, so we can move on to Deo Gracious. A very nice name, eh? And we'll be looking at surveillance of viruses and also discovery of viruses. Thank you very much. And as you present, the timing is there, so keep checking on your right to just see that we are okay with time.
Thank you so much for the kind introductions. I am Deo Semwanga. I'm a principal research scientist with the MRC unit, and I head the sequencing platform at the unit, in addition to other roles at the UVRI. I will try to catch up with the time. At least I've learned some lessons of being the first presenter. Peter, could you please help with that? It's now fine. It's now fine. It's happening again. So my talk is on pathogen genomic surveillance and discovery in the country. I must emphasize that this is really a collaborative piece of work, working very closely with the UVRI, as the Ministry of Health, and several partners in the country as well as the region. Yesterday, Dr. Lutwama had an elaborate presentation to do with the status of our current outbreaks in Africa. And as you are all aware, we are currently dealing with a concurrent outbreak of Mpox as well as Ebola virus disease. This is a really very important slide. I did borrow it from the CDC publication, which is emphasizing the role of the UVRI in viruses and bacteria discoveries in the country, dating way back in the 50s. And I must read out and quote what is written over there. The UVRI has led the way in identifying the viruses and bacteria that cause these new diseases. This is quite a very important aspect that the UVRI brings into this pathogen discovery work. And we have leveraged our close collaboration with the UVRI as well as the Ministry of Health to venture into pathogen discovery work, as you will see later on. A lot of capacity over the years has been built at the MRC unit, dating way back in the early 2000s, where these molecular sequencing facilities and the other molecular labs have been set up, including the various unit platforms, such as the general population cohort, the immunology platform, the sequencing platform, but also leveraging the capacity to analyze big data utilizing the Uganda Informatics Center. I'll talk about our sampling and testing approaches for HIV molecular epidemiology work. This work has mainly utilized the various population cohorts that the unit has set up. As I mentioned, the GPC. Recently, we had the Good Health for Women project cohort in Kampala among high-risk women, and also quite a number of fishing communities around Lake Victoria. I've already mentioned the capacity that we do have at the unit. Initially, of course, we were utilizing mainly Sanger sequencing, but with technological advancement, we are able to use next-generation sequencing and analysis using the various available analytical packages, which does enable us to effectively look at HIV transmission networks among the various populations and be able to pinpoint sources of infections to inform targeted interventions. I won't spend much on this slide because Professor Pontiano did talk quite a lot of what contributions the MRC has done since its inception over 30 years ago, starting with section network work within the various populations, which eventually graduated to molecular epidemiological approaches, further characterizing HIV subtypes in the country, and also looking at the evolution over the years, and also looking at the effect of the different subtypes on disease progression. I've just selected a few of these publications. This is also a major activity that the unit is involved in, HIV drug resistance. We do host the WHO national as well as the regional HIV drug resistance lab. So we are working very closely with the ministry, and we've done quite a lot of surveys to inform treatment guidelines in the country. This is one of the contributions that we have really done in as far as treatment guidelines are concerned. I'll move over to one of the flagship networks, which is the Pangea Consortium that is funded by the Bill and Melinda Gates. This is the phylogenetics and networks for generalized epidemics in Africa, which brings together quite a number of players, including the MRC and other institutions in Uganda and South Africa, which aims to utilize phylogenetics and phylogenetic data in addition to socio-epidemiological data to look at transmission networks to inform interventions. The key aim here is to identify those populations that at highest risk of transmitting, as well as those populations at risk of acquiring infections. This network has really done quite a lot, and this slide summarizes the major highlights of this consortium. We have been able to highlight the sources of recent of infections, whether these are really from recently infected or chronically infected. We have looked at the size of the transmission clusters. In the north, most of the clusters are really very huge, whereas in our population, For example, in Uganda, we did it many years ago. We did show that the transmission clusters are really very small, mainly involving a few individuals, 2 to 5 individuals. But we did confirm that indeed most of the transmission clusters in our setting in sub-Saharan Africa are mainly small clusters. This is probably because our epidemic is a generalized epidemic, as opposed to the north, which is concentrated mainly among MSMs and injection drug users. We further went ahead to look at whether the transmissions are mainly happening within communities or across communities, but also looked at which age groups were at most risk of transmitting. For example, we found that 25 to the 40-year-old men are most likely to transmit. Who transmits more? Men were 2 to 3 times more likely to transmit. And these were really findings which had earlier been documented in our populations. Anne has just presented something to do with recombinants. We have, over time, looked at the evolution of our epidemic. We had access to samples from the earliest, during the early time of the epidemic in the 80s. We compared the subtypes in the early 80s, and as you can see, majority of the infections were due to pure subtypes. In our setting, it was mainly subtype A and D. That is more than 80% were pure subtypes, and very few recombinants, as you can see. However, from 2008 to 2017, the samples which were collected over that period of time, as you can see, 50% were recombinants. You can imagine Anne has presented at least more recent data from the transmitted founder viruses where they have documented close to 70%. I guess the situation is quite different at the moment. And this really highlights how fast evolving the HIV is. This is a major, again, output from this consortium. This work was led by Nicholas Bosa, who was a PhD student at the time. He did really confirm, in contrast to earlier suggestions, that the fishing communities in Uganda were in fact sinks of infections from the general population into these fishing communities. Interestingly, our colleagues, the Rakai Health Sciences Program, did indeed find similar findings. And this definitely was very informative to interventions. As we track the evolution of these viruses, as you're aware, it is very important for vaccines. We were able also, through Nicholas's work, to report the very first cases of the circulating recombinant form 10, which is a CD recombinant, which had earlier been reported in Kenya and Tanzania, and this was in the fishing communities. There's quite a lot of mobility among these fisher folks. So this really highlights how really these viruses are moving across the borders. I'm now switching over to the SARS-CoV-2 pandemic. It's quite a story that many of you have listened to. Of course, at the onset of the outbreak, the MRC labs did really prepare for the pandemic. We set and optimized diagnostic as well as genomic protocols in preparation for the pandemic. And the moment the very first case was identified in March 2020, we immediately generated full genomes from the very first cases, and we were able to track and trace the origin of the imported SARS-CoV-2 cases, and this informed the subsequent interventions by the ministry, which included airport screening and other ports of entry into the country. So during the course of this pandemic, we did quite a lot of sequencing, utilizing our sequencing platform to inform the Ministry of Health as well as the WHO on the evolving pandemic. So we tracked all these variants over time, from the alphas to the deltas to the Omicron. To date, we are still doing genomics for SARS-CoV-2, and we are contributing to the coronavirus network at the WHO. I want to highlight the contribution of the MRC to the SARS-CoV-2 pandemic. On your right of your screen up there, you see the global contribution of the various geographic areas, the genomes that have been contributed for SARS-CoV-2. Of course, Europe has the most, Africa the least. But when you zero down at the bottom on your left, Africa, Uganda has contributed quite a few compared to other countries. But for Uganda's case, I'm proud to say that the MRC has been very instrumental in provision of this genomic data, where we have provided more than 50% of genomic data that is publicly available on GISAID. I will now switch gears to the pathogen discovery work, where we, as I mentioned, we are working very closely with Dr. Lutwama, who is actually seated over there in his department in virology. And we are leveraging on the available Sentinel sites across the country for this work. The objectives, in addition to the surveillance work, is to asset development, and we are working closely with the Abbott Diagnostics, and we reach out to several health facilities and regional and national referral hospitals for this work. But one important aspect in this discovery work is the component of the mortuary surveillance, where we target mainly those non-trauma cases or individuals with inconclusive post-mortem results to do the virus discovery work. But we are also privileged, since we are working very closely with the ministry, we do have access to quality specimens during outbreak response. This is an example of how we are really reaching out. In addition to supporting the country, we're also supporting the region. We are supporting countries such as South Sudan, the Eastern DRC, as well as Republic of Burundi. I'm only presenting what we have done for the Republic of South Sudan during their recent hepatitis E outbreak, where we managed to confirm this here at the MRC. Professor Emma Thompson over there did contribute to this work. I now move over to the mortuary surveillance, which is really very important to us and very exciting aspect. And I will present among this, the various outputs that we've done. I will mainly present on this recent anthrax outbreak in the country in 2023, where there were unexplained deaths in southwestern Uganda, in Rakai, no, in Chotera, sorry, in Chotera. And initially these were attributed to alcoholism. However, we do work with the Mulago team, Dr. Sam Kalungi, who's a consultant pathologist in Mulago, who is part of this mortuary surveillance. He did really look out for, he did confirm that indeed this had nothing to do with alcohol consumption. So we did dispatch teams working close with the UVRI colleagues and Ministry of Health that went out to Chotera, collected very good specimens, where we eventually did in fact confirm that there was an ongoing anthrax outbreak in the country. And this really informed a subsequent surveillance work in the country. What impact has the mortuary surveillance had so far? On the onset of the Ebola outbreak in late January, the index case, the sample was from, it was a mortuary sample from the index case that was tested by colleagues at the Central Public Health Labs that did confirm, that picked up the Ebola virus disease. And subsequently, the colleagues in the virology department did confirm this outbreak. And genomes from this individual were generated within 2 days, and we did support the analysis of this data. And subsequently, on your right, as you can see, a directive came out from the Director General informing the countrywide health facilities to investigate all non-trauma deaths. So samples have been subsequently been sent to the Central Public Health Labs, the UVRI, for confirmation or rule out of Ebola virus disease. Turning now to the Mpox. As of today, we are almost reaching 4,000 cases, and that is confirmed lab cases. Those are the ones who have been tested. Now, when you, for the Mpox, the unit played a very significant role, again, in identifying the very first 2 cases of the imported Mpox virus. And this was, again, through the discovery work that we were doing. These were individuals who were crossing from the Eastern DRC looking for health care in Uganda, and we did confirm the very first 2. Genomic sequencing was done within a week, and we were able to identify and confirm that this was a clade 1B, which was directly linked to the outbreak in the Eastern DRC of Bukavu. And we have gone on to continue doing genomic surveillance as the Central Public Health Labs do the diagnostics and other colleagues, but we mainly contribute to the genomics. Oops. Peter, for some reason, I cannot move. Sorry about that. It's not moving. And it's problem caught up with me.
Share again. This one. Does it come?
Slideshow. Could you? You are resharing. Some IT lessons, huh?
This one.
This. It's already on the screen.
Okay, just bring the cursor here. Just bring the cursor here. Now you can slide.
No, it's in that mode. Sorry about that. So during the what I'm seeing here is different from what is here. Okay. Well, I'll use that. So one of the challenges during the outbreak was the number of cases that were turning up with Mpox-like symptoms, but were turning out to be PCR negative. So we were tasked with investigating this further. We did quite a lot of test kit evaluation in the country in collaboration with the ministry. where we did provide information on the performance of the available test kits, but we went further ahead to test these individuals that tested negative despite presenting with Mpox-like symptoms. And we did confirm that these individuals indeed were Mpox negative, but were co-infected with other infections, such as mainly chickenpox. 80% of these individuals were infected with chickenpox. We were also able to identify other co-infections, such as measles and the others. So what has been the contribution of the MRC in as far as diagnostics and genomics to the country's response to date? Again, on the left, you can see the global contribution from the US and Africa. On the right, in Africa, as you may see, Uganda, we have contributed about 7% of the genomes in GISAID. But at the bottom on your right, you can really see that the MRC sequencing platform has been able to provide close to 98% of the genomes that are coming out of Uganda. In fact, we will be submitting close to 200 genomes in the coming few days. Finally, we are moving into environmental surveillance and wastewater, which will include aircraft surveillance, which is very crucial for this kind of work. In conclusion, we've been able to timely detect outbreaks, and which has guided our response, and this has also made a contribution to the testing guidelines. This data is publicly available, which is supporting diagnostics. Again, as you have seen from Anne's presentation, this data is currently being used for vaccines, and Dr. Serwanga shortly will be presenting what she is currently doing, especially in SARS-CoV-2, utilizing this data, and even the Mpox work which is ongoing. Therapeutics is again another aspect that is coming off this. Finally, capacity building. We do have quite a lot of doctoral students whom we're training at the moment as a unit, and we are reaching out to several partners locally and within the region. I apologize if I have not recognized you in this acknowledgement slide, but there are very many people who have contributed to this. Thank you so much.
Thank you so much. Okay, I hope all of you are keeping your questions. Our next speaker is Professor Emma Thompson. She's a professor of infectious diseases at MRC, University of Glasgow, an expert in virus evolution and next generation sequencing, collaborates with UVRI on emerging viruses, and leads research on cross-reactive antibody response on coronavirus infections and using the next generation sequencing. So Thompson is going to give us a talk on high throughput seq serology using phage display. Thank you very much.
You have it? You don't have it? Okay.
It's not here. I thought you had all of them. Use the stick. Let's use your copy. Yeah. Just put it.
Or this side? I'll say hello while you're loading. Good afternoon, everyone. It's very lovely to be here. And I've been working with UVRI now for 8 years. I was asked to come for 1 week by colleagues at the MRC, and that was because in parallel we were setting up next generation sequencing, and so this was becoming part of the strategy also at Uganda Virus Research Institute, and the plan was for a 1 week visit which has turned into a lengthy 8-year collaboration. There we go. So I'm going to continue the theme on, that's not it. I'm going to continue the theme on virus discovery and then some of the newer methods that we hope to use in Uganda to look for exposure to a variety of viruses. But I thought I'd give some background first on the virus discovery work that follows on well from Deo, and Deo has also been very involved in some of this work, I should say. Sorry, we're just waiting for the slides. I should also say I'm employed by the MRC University of Glasgow Centre for Virus Research, but also the London School of Hygiene and Tropical Medicine, just to acknowledge both of my affiliations. Thank you so much, thank you. Okay, there we go, lovely, thank you. All right, hopefully people online can hear and will let us know if they can't. So I'm going to talk a bit about enhanced virus surveillance and intervention strategies, which includes some newer methods, including next generation sequencing serology or FIPSeq serology. I'll go very fast through the introductory slide, but just to say that Ian Lipkin's group in 2013 estimated that there may be as many as 320,000 viruses that infecting mammals that we have not yet identified, which means that there are rich pickings for identifying viruses, particularly in areas like Uganda, which have very, very high biodiversity. And our behavior has changed substantially to increase the risk of transmission of viruses with pandemic potential through anthropogenic change, including climate change, but also through flights. It took me about 12 hours to get here from Glasgow. That's also how fast a virus can move. So this study, which started with a 1-week visit to the MRC, was supported by Professor Pontiano Kalibu. Thank you, Pontiano, for the invitation. Has now grown into quite a large project. And through this arbovirus infection study, AVI, we've supported a number of colleagues. In green are the fellows from UVRI, and in black are the fellows from Glasgow. There have been 10 PhDs, including those supported through the MUI scheme, which Professor Alison Elliott ran for a number of years. And also I now have some research associates who have grown through that scheme, have been funded, for example, through the Peter Piot Fellowship at London School of Hygiene and Tropical Medicine. And we've had clinicians visit simply to get the experience of working in a different setting like Uganda. So AVI was actually set up to initially identify causes of acute febrile illness in Uganda. And it was funded through the MRC and initially through an intermediate clinical fellowship through the Wellcome Trust. And we decided to work at 3 sites in Uganda, Ruakasezi in the west and Wakiso, and to identify viruses that might be causing acute febrile illness in patients attending healthcare centres, alongside healthy controls from the same settings. To identify within the same 5-kilometre radius viruses in mosquitoes and ticks, and to identify viruses in bats, rodents, and domestic livestock. And then aim 2, which is something that we're working on now, was aimed more towards enhancing virus surveillance and intervention strategies for health preparedness in Uganda, and this has now been funded by NIHR. And we also have a large award from the EEID scheme, as I'll outline a little bit later. But these questions involved thinking carefully, perhaps more carefully, about how metagenomic and next-generation sequencing and target enrichment sequencing might be utilized cost-effectively in a setting like this. Also to carry out sensitivity and specificity analysis, and to think carefully about, is this something that could be done outside of research as part of a public health intervention in different settings? So in people with key clinical syndromes, including acute febrile illness, meningitis, respiratory illness, occupational surveillance, which I'm going to talk about in a minute, more detail, but we're working with a number of different groups, including healthcare workers, bushmeat hunters, otherwise known as reformed poachers in Uganda, and employed through the ministry to assist with tourism and so on, redeployed, and farming communities. And then also we are working on wastewater sequencing. So in one of our initial studies, this was really the pilot study, we put together 2 cohorts of patients with acute febrile illness, one which I ran through MRC funding, and the other of which was run by UVRI and CDC, to identify patients with acute febrile illness of 2 to 7 days duration. We collected samples from 82 cattle, 97 rodents, 98 bats, 2,754 ticks and 10,000 mosquitoes, and sequenced them. The clinical recruitment was done pretty carefully. We used stethoscopes without earpieces and insisted a bit on fairly high-level PPE. And in fact, Andy Blunsom, one of the doctors who came across from the UK to get experience in Uganda, identified at least one case of VHF through this study, so I was quite glad on insisting on this. But I should say, though, that there are issues to think about here when working with local physicians and doctors and medical teams, because this isn't necessarily how PPE is done in the field routinely. And then we collected blood, urine, CSF, and throat swabs. And as I mentioned, the inclusion criteria was of a short duration, acute febrile illness, aged more than 2 years, and malaria negative, with the absence of other key symptoms, so obvious pneumonia and malaria negative. This is the team collecting bats. This team was coordinated by Professor Robert Chitio in Makerere University. And you can see at the bottom right there, bats having a sugary drink. It helps them recover when you send them off again into the sky after capturing them. And this is Martin Mayanja on the left-hand side, identifying mosquitoes. And he did all the work of identifying mosquitoes and pooling them by district and also species. And then on the right, Stella, a team who did the same for ticks. And really, the sequencing methods were very similar, except that we pooled the ticks and mosquitoes and homogenized them, and samples taken from patients and from animals were done individually. We used both target enrichment, VERCAT from Roche or Twist. These are oligonucleotide probes which pull out all known virus families. And one of the key findings was that, in fact, this method is far superior to standard metagenomics because it lifts the number of viral sequences that you detect by at least 2 logs. And so it's a far more sensitive method. Also, it can be used for finding new viruses, and so the concern of missing those is actually not that high. I'm not going to talk about the bioinformatic workflow, but it's quite complex. And not everyone wants to do it. I like it, but others don't like coding. And so one of the things that we've been working on very carefully has been to make a more user-friendly type interface for this type of analysis. And in fact, this is something that colleagues here are using beta testing, and we're also doing this for the NHS in the UK. So basically all you have to do is connect to the server, access your raw files, and then get an output of phylogenetic analysis over time without having to think about how the scripts work. These are the sites that I mentioned and the initial findings in human samples, so, which are shown in panel B here. And critically, we detected a number of viral hemorrhagic fever viruses which were not considered because they did not present, none of them presented with hemorrhagic symptoms. And so these viruses are obviously circulating under the radar and include viruses such as Crimean Congo hemorrhagic fever virus, which I'm going to talk a little bit more about in a minute, Rift Valley fever virus, yellow fever virus, dengue. I should say dengue we detected both genotype 1 and 3 in this study, so there is dengue in Uganda. Hepatitis viruses, bloodborne viruses. Now, respiratory and gastrointestinal viruses were detected in blood, and so this really indicates the high burden of disease from these viruses. I'm not talking about stool samples or throat swabs here, and it should be relatively rare that you detect some of these in blood, other than measles, for example, which is often found in blood. But this does indicate that there's a high burden of these diseases here, which isn't a great surprise. So now the mosquitoes, and this work was done by Martin Mayanja, Sherry Nashraf, Alfred Sekagiri, and Mark Nebo, working together over a number of years. And I won't kind of go into every one of these phylogenetic trees, but just to say that most viruses detected in mosquitoes were novel species within known viral families. And some of these viral families harbor viruses which are pathogens, including the Flaviviridae, the Rhabdoviridae, and the Bunyavirus family. There were many. Almost every virus we found in mosquitoes was a novel virus, and it indicates a very large biodiversity which is as yet unexplored. When we did a bit of maths to find out how well we sampled, we used a number of measures, including species richness, Shannon entropy, and Simpson index, and we found that we were probably detecting the dominant species reasonably well, but certainly not detecting rarer species, and a much higher amount of surveillance would have to be done to identify all the viruses that there are in Uganda. Ticks was a very similar story. The only thing with ticks, so we detected flaviviruses, including quite interesting flaviviruses, for example, Trinbago virus, which is not novel. It's a segmented flavivirus, so it's kind of interesting. And others within known sort of viral families that you might expect. Again, there were many novel viruses, and also in this case, we detected CCHF commonly. So around 1 in 50 tick pools were positive for the Crimean Congo hemorrhagic fever virus in multiple sites. We also found, interestingly, Dugbe virus and Nairobi sheep disease virus, which are orthoneuroviruses in the same family. And we found Dugbe was actually twice as common in parts of Uganda, particularly the northwest of Uganda. And there have been case reports of infection in humans, both of Dugbe and NSDV, and I do wonder a little bit if exposure to these viruses may influence the immune response to CCHF later on. We also discovered a novel virus. I'm sorry for the size of these trees. I won't even bother asking you to try to put your glasses on to look, but in the top left panel, this is an nairovirus, and in fact, at the very top of that, highlighted in gray, is a completely novel orthoneurovirus, which we've called Masira virus, which is one of the local languages, meaning tick from that region, so tick virus. And we don't know if humans are exposed to that or not. Similar to the mosquito viruses that we found, we don't know if humans are exposed to these viruses and if they cause disease or not. And so we started thinking about solutions for this, because it's all very well stamp collecting viruses, but actually what we really want to know is there a burden of disease associated with them, and how can we look for that? So because we found loads of new viruses, we decided to move on to thinking about high throughput serology as a method for looking to see whether or not, at the very least, people in local communities were being exposed to these viruses. And I'll go on to describe that in a minute. The story with the tick sampling is very similar to mosquitoes. Basically, we probably found some of the dominant viruses, but not very many of the rarer ones, and you'd have to do a lot more sequencing. One of the key findings from this work was that we found Crimean Congo hemorrhagic fever virus in the samples. And this CCHF is quite diverse, particularly in the M segment. There are very, very diverse branches here, and this probably indicates that there are a number of different viruses circulating in Uganda. We found one of the very divergent sort of clades in the middle of the M segment here, you can see in the phylogeny, was found only in ticks, and I don't know if that particular clade is also found in humans, but it's something that we'll be interested to look into. And if we had better serology, we might be able to tell. At the moment, serology for noroviruses is very, very non-specific, and you can't really tell the difference between a serological result which indicates exposure to even different species within that group. This work was done largely by Stella team and Shirin Ashraf, who's a postdoc in Glasgow. And it led on to us looking harder for CCHF. So as I mentioned, 1 in 50 tick pools were positive for CCHF, but also more like 1 in 25 were actually positive for Dugbe in certain parts of Uganda, and then these other viruses. And also we found another 20 novel viruses in ticks. In undiagnosed febrile patients, we found CCHF in both I only showed the data from one acute febrile illness study, but we found CCHF in the other as well. And adding up to around 1 in 300 acute febrile illness cases likely to be caused by CCHF here in Uganda. The seroprevalence is very high. I don't know, this thing's slightly in the way here, but well, I'll just try and remember the numbers. So humans, it's around 1 in 3, between 1 in 3 and 1 in 4 people are seropositive for CCHF in farming communities. In cattle, it's 9 in 10. So there's clearly a lot of this virus around. And we looked at associations with exposure to CCHF in farming communities. This work was very much led by Stella. And interestingly, so we looked at the kind of standard risk factors that you might expect that WHO might recommend that you look at, including tick bites and slaughtering animals, also crushing ticks with your bare hands. But one of the, and I've summarized the risk factor analysis here, I've cut out all the non-significant findings, and this is just the risk factors in farming communities. But one of the key findings, and this was an observation by Stella, was that people collect ticks for roasting and eating in northern Uganda, in the northwest and in the northeast of the country. And this is associated with an adjusted odds ratio of 18.9 in these communities. And this is an engorged amblyoma tick on someone's hand, and it's a common practice. I can see in Scotland we would look at this as a sort of mini black pudding. We like that. I suppose that's, you can see it's quite a good sort of protein source of nutrition, but it's probably pretty problematic in terms of exposure to noroviruses. I just want to say one thing though, so thinking through this carefully, it might be that people could be exposed to a different norovirus, and we're picking up norovirus positive serology, which we're assuming to be CCHF, but actually it could also be that people are kind of pre-immunizing themselves with exposure to Dugbe, for example, or Mircea or another related virus, and that could provide protection. So I think we have to think very carefully about interventions. I suspect it's not a good idea to pull the ticks and be exposed, but I think we do need a little bit more work on that to understand it better. I'll be quick with this slide. So this is just about the kind of symptoms and risk factors associated with some of the viral infections that we found in these areas, and I think the key messages here really are, firstly, that a lot of the infection is arbovirus driven, and the risks associated with a viral infection are really driven by that exposure to arboviruses, and with a reduced risk of infection with wall spraying and a higher likelihood of viral infection with symptoms such as joint pain, which indicates the burden of disease, probably of Onyong rather than chikungunya virus in the country. I would also like to highlight that all the cases of hemorrhage and fever that we looked at were associated with other diagnoses, including malaria, bacterial infection, dengue, echoviruses, and so on. And so actually, VHF viruses do not always present with hemorrhage. In fact, perhaps more often they don't. And I think this is something we've learned for a bit from Ebola. Maybe Miles will talk about it. And it's important in these endemic settings to realize that these viruses probably do pop up now and again without classic symptoms. We went on and looked into some of the other viruses we found. So one of the viruses we found was Ledantec virus. This work was carried out mostly by James Shepherd, who's a clinician who came over to Uganda for 6 months and worked up in Arua district, lived in Arua district, recruiting patients. And he carried out this work, so we sequenced the virus. It's a rhabdovirus. It was first described in the 1960s and hasn't really been described since. But we found it in one acute patient, and in fact in someone who was living with that patient had also developed symptoms, so we recruited them as well. And what we found was we found the virus in the index case. It's the genome here, classic sort of rhabdovirus genome. And then we made an ELISA and a neutralization assay using a VSV a pseudovirus system. And we found that we demonstrated neutralization and ELISA positivity in both of those people. And also we did some immunocytochemistry, and you can see quite nicely here in the kind of AFI patients that we recruited that there's dual staining for IgG directed against the Ledantec virus on the surface of cells which are expressing that virus. And then we went on so James went on with the help of colleagues here, particularly Robert Downing, who helped us to get some antenatal sera. We looked at antenatal sera from across the country, 1,000 cases. And what we found was that actually Ledantec exposure is extremely common, and it's quite localized, so particularly to parts of Uganda, which, for example, central and western Uganda, but it's almost absent in northern Uganda. What that means, not quite clear. In mice, Ledantec virus causes it's neurotropic, and it can cause neurological disease. And of course, it's a rhabdovirus, member of the same family as rabies and other Chandapura virus, which can have neurological sequelae, although it's very distant from those. So we need to understand a bit more about this virus, I think. This is a novel one. I'm not going to spend ages because we're probably running short on time, and I want to move on to other things, but we've also found novel viruses. This is a novel Champ-Hama parvovirus found in one acute febrile patient. We're just working on the serology at the moment, so we haven't published this one yet, but it's most closely related to Tasmanian devil-associated Chaparrovirus 1, so definitely novel, and what it does, I don't know. So that leads me on to just the last 2 or 3 slides, which really I want to discuss in a bit more detail. So over the last 3 years, and particularly this has been driven by Shirin Ashraf in Glasgow, but also other colleagues, and we read a paper some time ago, 2014, from Stephen Elledge's group in Harvard, and they were talking about phage display, and particularly for detecting autoimmunity at high throughput. And Shirin Ashraf has designed a number of libraries which use this technology to look for viruses, including emerging viruses that we've found in the mosquitoes and the ticks and so on in Uganda. The technology is fairly straightforward. It involves manufacturing oligonucleotides which are optimized for expression in E. coli. They're expressed in T7 phage, and you make a large phage library. These libraries tend to have around 200,000 peptides in, and you can put in hundreds of viruses. You could also put in other pathogens. Because we're virus people, we haven't done that, but you could be putting in bacteria, fungi, and parasites. And what you do is you express those, and then you immunoprecipitate the phage with antibodies or just serum from people in the community. And what that does is you immunoprecipitate the protein or the peptide that's expressed on the surface of the phage. You pull that out, and in fact, you can pull out many hundreds of phage or thousands. And with that technology, you then are left with phage that's been pulled out by antibody, and inside the phage, you have the genes of interest that encode the peptides. So rather than doing a sort of classic ELISA, what we do is use next-generation sequencing as an output here. And what you can maybe see in the bottom right-hand panel there is an NGS readout. It looks like a classic sort of virus coverage readout. This is SARS-CoV-2, and in purple there, that's the spike protein or gene. So we actually sequenced the gene, but what we've done is we've immunoprecipitated the peptide, so really it's representative of the peptides from the virus. And you can see the parts that are identified epitopes, right down to the epitope level, what's recognized. These are linear epitopes, so this doesn't help for conformational epitope detection. There may be other ways of thinking about doing that in the future with different methods, but it really does help you to detect antibody responses. And so I've got a little bit of data to show here on FIPSEQ. The first is work that we've actually done on coronaviruses. This is using a library that Shireen designed called RESPScan. It's got 100,000 peptides from multiple families, including, well, they're all listed there, adenoviruses, coronaviruses, etc. And as I mentioned, if you were to have this done, you're basically going to sequence effectively your entire exposure over time, your historical exposure to viruses all at once. What you can see here, these are vaccine. This is actually the DOVE study, which we ran in the UK. It's people who've received deployed vaccines. In the UK, we used AstraZeneca, Pfizer, and Moderna as mRNA vaccines. And then there's also natural COVID-19 infection, and then at the bottom, pre-pandemic controls. And what you can see here, again, if you just sort of look at the spike, you get these very quantitatively high, this is semi-quantitative, it's based on a Z-score, high spike responses in the mRNA vaccinates, but actually not quite so high in the AstraZeneca. And in natural infection also you get these spikes, but also you see in the end there, you can have, there's a spike there. And in pre-pandemic controls, in fact, there are one or two slight peaks, and that comes from conserved coronavirus epitopes, which are present in other coronaviruses. So we started looking at this now for sorting out norovirus exposure. So this is, and these are sort of maximal responses from the AVI study. You can see on the CCHF side on the right there, these are M responses, and these are pretty, it confirms what we found with conventional serology, but it kind of locates better where the epitopes are. And then with Dugbe virus, the related one, actually these responses look pretty flat. So we're now going to go on and look at all the other orthonoroviruses that are circulating and all the other areas. It's very preliminary data. That one spike is a very conserved epitope, which is present in many viruses. Other than that, it's pretty flat. This is my last slide. So these are the kind of pieces of, we make a big effort to share our data with local communities. We've done a number of training. We've also had the Welcome Connecting Science, bioinformatic training. This is a course that I co-lead, which is normally run at the Sanger Institute, but we brought it out to Uganda a couple of years ago. We try to reach people that don't have such loud voices, children, for example, with a Ludo game made by one of my PhD fellows, also females and younger men, as well as village community leaders who tend to be more middle-aged or older men. And then, we work with a number of communities in order to find things out, like the fact that ticks are eaten, which you wouldn't find out about otherwise. And I think this also highlights the amazing sort of capacity you have with an international team working together on this science. And yeah, I'll finish there. This is a summary. There are many uncharacterized viruses in mosquitoes, ticks, and humans in Uganda and other parts of the world, no doubt. CCHF is almost certainly underestimated as a cause of acute febrile illness in Uganda. And I think that there's a case to be made for sentinel surveillance at a population level with agnostic or semi-agnostic sequencing. And finally, next generation sequencing serology has huge potential for resolving cross-reactivity and also identifying things like early species jumps in the population. And I hope that we have a robot that we plan to bring to UVRI, which will automate this. And that's what I hope to do in the next couple of years. We'll finish there. This is the team. Thank you for funding from MRC and also LSHTM. Thank you.
Thank you. Thank you so much.
Thank you.
Thank you. So we move on. Dr. Jennifer Sewanga. Osere? Seruanga, correction. She's a principal research scientist and immunologist at MRC, UVRI, and London School. Also an assistant professor at London School. International recognized for work in antiviral immunity and vaccine research. Leading studies on HIV, Ebola, COVID, and more. And also a leader in epidemic preparedness, immunological techniques, and research and mentorship. She's going to present us a talk on, in the midst of latest scientific battle, COVID-19 variants, immunological insights from population response to infection and vaccination. Karibu.
Thank you very much, Dr. Anzala, Professor Anzala. I'm going to take you through an overview of COVID-19, the way we saw it in this country, going through the waves and also trying to understand the immunity to the epidemic as it moved. I'll talk about the waves and then how we compiled the cohort, measured the antibodies, and then looked for the functions and our journey and where we want to be and how we want to use what we've learned for the next epidemics. So this is the epidemic that we had. The prototype strain that everybody talks about did not happen very much here. Our first peak was the A23, which is the Ugandan strain. And then we had the Delta that killed most of the people. Most of our deaths came from the Delta, and then we had the Omicron, and then continued with emerging Omicrons. So by that, at the beginning, when the country went into lockdown, we started collecting specimens. We partnered with Entebbe Hospital and Masaka Hospital, because in this country, as soon as the lockdown was announced, then only truck drivers were allowed to move, plus a few essential workers. So they started testing these truck drivers every time they passed out at the borders. So when whoever registered a positive PCR would be put into isolation. So this is how we collected our cohort, not because they were very sick, but because they were PCR positive. And most of our cohort is really asymptomatic or people with 1 or 2 symptoms. We were also able to collect the contacts and those who were not exposed at all. So we have the comparative groups. And later on, we were able to access more recently those who went into ICU, and we are also understanding how those responded. So initially, there were many kits, but the kits were expensive, so we optimized our assays and also used a number of controls, including the WHO controls that were available at that time. And we used this, plus some pre-pandemic sera, as well as sera which was collected from our truck drivers, to optimize and also work out the cutoffs for the cohort. This is a summary of what a summary of what we saw in the cohort of 320 truck drivers. What I want you to note is that right from the beginning, we have very, very high responses, meaning that we had most likely a recall response. This is very close to PCR, and they are very high responders. Our initial peak generally for the cohort was around 35 days, but importantly, there is a very, very high response of binding antibodies, IgG, at the beginning. And this stayed for quite some time and then started to rise, probably because of reinfection. So we were able to pull out 22 individuals that never got reinfected at all. And what we pick from this slide is that the N, antibodies to the nucleoprotein, fed much faster, and the spike is more prolonged. So if somebody wanted to use these 2 proteins to kind of get a rough idea of how is the exposure to COVID, it's better to use the spike because the nucleoprotein didn't last as long. We were able to compare some data with our collaborators in the UK, the King's College London. This slide shows the comparison between the Ugandans and the UK cohort. We picked out people who were more closely related to the cohort that we have, those who have very mild symptoms or no symptoms at all. And the red is the Ugandans and blue is the UK cohort. And we were more interested in the very early days, around 10 to 14 days, because here you either went to isolation and they would let you go out because you became PCR negative. So it mattered. The beginning of the initial response is what mattered for you to either go to ICU or to go back home. So what we see here is that the initial response is much higher in the Ugandans compared to the UK. This was kind of trying to understand why is COVID different between the two geographies. But when we looked at also the neutralizing antibodies, this slide is categorized according to the titers. The darker green is the highest titer, and as you go down, the dark brown is the very low titers. We also see much higher titers in the early response when you look at the Ugandans. This has been accepted in vaccines. You can read more about that. I told you before that our initial peak was A23.1, the Ugandan strain. And so we've now looked at, because initially all our assays were using the prototype strain, which is the Wuhan strain D614G. So we reevaluated our samples using A23, and what we see is that generally there are higher responses all through to the A23 compared to any other strains. And when the vaccines got available, we were able to get back to our truck drivers and get some of them to be vaccinated. And we see again that A23 responses, neutralizing titers, were much higher than to the prototype strain, implying that this population was primed by the initial exposure to the A23. We got interested in understanding more if there was anything different about the asymptomatic compared to the symptomatic. And our symptomatic means 1 to 3 symptoms, so really mild infections. And we broke up the spike into 2 pieces, the RBD and the S2. For S2, we feel that it was implying the neutralization, and RBD is for the neutralization, and the S2 is more of the fusion functions. And what we saw is that the people who were asymptomatic were likely to have more of both the RBD and S2 responses. They greatly correlated with having both those two. While those who had one or two symptoms, they had one of the two and not both. We have been able to look at the vaccines that were given in the country. We had 5 different vaccines, and the general picture that we see is that the peaking of the responses is earlier than what we see in most other places, where peaking is from around 1 month. Here, within 14 days, there was a significant rise after the first dose. We didn't see that for CoronaVac, but by the time CoronaVac was given, also there was a lot of prior exposure to infection, and so probably the people had reached some kind of a peaking of their antibodies. But generally, the peaking was earlier compared to other populations here. So we have also looked at the different days since vaccination, day 0 being our baseline, stratifying our participants using 3 vaccines. The top orange one is the Pfizer, in the middle is the Chadox, the AstraZeneca, and down is the dark brown is the CoronaVac, which is the inactivated, and we wanted to see if there were differences in these. Initial looking at them, again we see if you look at the day 0, the first panel, the day 0, we see that there's a high predominance of S2 directed responses in these participants. So again, the early recall is there in the vaccinees. And this was present both whether somebody was HIV positive or negative. So the S2 directed response was quite great in this population. Here we looked at this as a summary of the responses to either the RBD or the S2, and the darker brown shows us higher responses to RBD, and the bluish areas show us higher responses to the S2. What we see here is that most of the responses to the vaccines, the other two vaccines, was against the RBD part of the spike, but the CoronaVac was mostly inducing S2-directed responses. So we were interested to know what is the S2-directed responses imparting in terms of function. We looked at the binding antibodies against the different variants and also considered the S2, and we see that there is quite a lot of correlation between targeting of the S2 and the ADCC function, which was measured as CD107 degranulation. So, and this was more associated with the lower panel, which is the CoronaVac, meaning that much as it wasn't giving a lot of neutralization, the functions that it was using to protect was largely non-neutralizing. We have looked at the different strains up to the Omicron, the more mutated Omicron, and we see that the population has really lost neutralizing antibodies to SARS-CoV-2. We have only received one vaccination. We didn't have the boosters of the other types, and the population has lost the protection if you are measuring neutralizing antibodies. So we are now interested in knowing if there are other functions which are unmeasured as we reach the level of so many variants that have evolved. So we are moving this work forward to look at more functions. We want to look at non-neutralizing antibodies there, but also we want to look at the other arm of immunity, which is the T-cell functions, and we are going to work with partners to do a more detailed polyfunctional characterization of the T-cell functions. So initially we had looked at, used the pre-pandemic samples to test for cross-reactivity, because everybody was suspecting that Africans were not, they were having mild infection because of pre-pandemic exposure. And we did publish and found that there was very low cross-reactivity using the spike. But more recently, when we saw that there were differences, if you used the different bits, the subdomains of the spike.
Reported in Uganda quite a number of years ago, but you wouldn't really tell whether it would be of public health importance. So I think this is really a discussion that should be really ongoing. Yeah.
Maybe just to add, these are questions from online, and maybe Jennifer, we can start with you. What is the update on influenza virus? Is there any update on influenza? Do you do any surveillance on influenza? And if so, what is the interaction between influenza and corona?
Professor Dr. Lutwama is around, and I know that they have a section that is actively doing surveillance for influenza, and it was there even before we started on COVID-19. We haven't done any interaction work, but surveillance is ongoing. Yes.
And then the other question from the online is, and then maybe this comes to you, Dio, and the others, what is the extent of support for veterinary pathogens, and especially those with potential to cross over to humans? And I think Thompson, Phil, all of you can respond to this. Because we are now in the realm of One Health. So how do you bring all these things together?
I think the question comes at a very right time when, for example, the Uganda Virus Research Institute is now the designated East African Community Center of Excellence in Virology. And right now, they are integrating the One Health aspect. In fact, they are going in as far as rolling out mobile labs to do this surveillance among humans, but also working very closely with the animal health experts.
I I could say that I think that, for example, FIPSEQ technology could be used in animals just as easily, and so we should be able to identify what the exposures are to hundreds of pathogens at once in animals potentially. And clearly, the zoonotic risk is something that has to be explored deeply, and probably not one pathogen at a time, because there are too many.
There is an emerging hepatitis E virus. Now the question here is that, is it zoonotic? And if so, what's the reservoir? Hepatitis E virus, DO and the others. Hepatitis E.
I think I would pass this over to Emma, because the case that I did present for South Sudan was quite unique, because there were quite a number of deaths which were quite unexplained. A lot of VHF testing was done until when we did the metagenomics testing to confirm the hepatitis and also isolating full genomes for the hepatitis. The issue of reservoirs, I don't know whether Emma, you have a comment on this.
So some hepatitis E clades are found in zoonotic reservoirs. I guess it would be important to look. I'm not sure that we've done that, but others are spread more human to human, and certainly I think in this case there was evidence that that's probably been happening for quite a long time. When the molecular philo work was done on that, it looked like probably the virus had been circulating for a number of times in the region, and actually we found this similar viruses in Uganda as in South Sudan as well, so probably throughout the region for a period of time. And in fact we found this also in Europe. You know, we just don't look for it always, and so we miss cases. I think there's a lot of human-to-human transmission would be my guess with this particular clade, but there are others that you might expect to see in pigs, for example, and other animals.
So back to the audience again, before I go back to online. There's a question somewhere. Oh yeah, influenza, yes.
Well, just a comment on influenza. Yes, we have influenza in the country, and there is still a little bit of COVID going on. We do not get very many people who have got both influenza and COVID, because of course there are very few cases of COVID. We are beginning the influenza season. As the rains begin, the number of influenza cases increase up to September. There is a slight decrease between July and August, again because the rains go down a little bit. So we have some kind of correlation between influenza and the rains, but for COVID, it is that kind of correlation is not there. And of course, the number of COVID cases continue declining as we move along. Probably they will completely disappear. Thank you.
Oh, thank you. I saw a hand somewhere. Yes. A microphone in front here. Yeah.
Good afternoon, everyone. My name is George. My question goes to Dr. Ann. It's relating to transmission, transmitted founder viruses. Could you please elaborate do the transmission routes in which the person contracted HIV affect the genotype of the virus, the person you find in that person?
I'm not sure I get your question right, but maybe what I didn't explain was that the transmitted founder viruses we do talk about are among the heterosexual transmissions. That's where the mucosal barrier plays a role. When it comes to MSMs, there's no mucosal barrier per se, so I'm not sure. But when I talk about the transmitted for the studies that I was presenting, I was majorly focusing on heterosexual transmissions. Then you do ask about the genotypes or subtypes? Whether they are different?
The question is, does the route of transmission, let's say maternal to fetal or sexual transmission, does it affect the selection of which virus will be favored to?
Not very, but I think whether it's vertical transmission or heterosexual, the virus that crosses the mucosal barrier will just be one that is fit, for lack of a better word, one that is able to overcome all the different barriers at that level and is able to cross over into the new infection. It has no connotation to the type of virus when you come to subtypes. Any subtype can cross as long as it's fit, but just that for our studies, we showed that the ones that recombined between the A and D were more fit and they were more transmitted for the heterosexual transmissions. Yes,
Okay.
Pontian.
Okay. Okay. Go ahead, Pontian. Two more.
Hello. Yeah, it's an important question. It's mostly what she's talking about, sexual transmissions found in heterosexual, but also in MSM. But where you find that barrier broken and you find many variants being transmitted, like if you have STD and there's an effect on the mucosa that can affect that filtering, sieving, and you get multiple variants transmitted. If you have intravenous, you want to see that barrier, you want to see those single transmission. So indeed, the type of transmission and the type of the integrity of the mucosa does affect what she's talking about. So, yeah.
Okay. Now, in conclusion, there are two questions from online. Jennifer, the first is on you. SARS-CoV-2, regarding SARS-CoV-2 in Africa, there's a theory put forward that in West Africa, the malaria infection has impacted immune response in a way that meant COVID disease was less severe. Is this credible in Uganda?
We haven't done any work on malaria interaction, but I've actually read that paper and it was convincing. So they did see actually that there was an interaction and an effect. So it doesn't have to be done in Uganda, but it can be done elsewhere and it applies.
Okay, thank you. And then the last one, maybe Dio and the others. Have you found other coronaviruses in the regional bats or other animals in African countries?
I'll pass over that to the virus hunter.
Bats, corona and bats and...
I can say that we found some coronavirus in bats in Uganda, but quite fragmented, so we weren't able to retrieve whole genomes from those, and I think probably requires some further follow-up work. They did look quite divergent. But I know Miles has got more data than that.
So we weren't looking for coronaviruses, we were looking for Marburg virus, but we accidentally found coronaviruses and found a number of them that were not too distant from SARS-CoV-2, but we have no idea yet if their spikes are able to bind ACE2 or other human receptors. And this is this extra sort of biology we're trying to add to the sequence to give us an idea about risk. But we're also finding interesting coronaviruses in UK bats as well. So there's a lot out there. Was it 320,000 viruses we don't know about? It'll take a lot of work to find them all, but they won't all be relevant, well, obviously. That's the extra work that needs to be done and funded to give an idea on potential human pathogenicity.
When we were looking at cross-reactivity and pre-pandemic, we also assessed for potential cross-reactivity to other coronaviruses, and we actually saw that there was circulating antibodies against other coronaviruses.
To conclude then, for us, the work we've been doing under One Health, we've been crisscrossing Kenya, looking at birds, looking at rodents, and we have actually found a variety of coronaviruses, both in birds as well as in rodents. So there is circulating coronaviruses among wildlife. Whether there will be a spillover, we don't know, but really it's an active area that requires consistent surveillance. So let's thank all our presenters, despite the hitch. This has been an excellent discussion. Thank you very much. Back to you, Jean.
Just to say thank you very much, Prof. Anzala and the presenters. We are going for lunch. Unfortunately, the time is short. We need to be back here by 2:30 for the next session. So see you then. Thanks.
Hello, welcome back from lunch. Kindly, could we take our seats? We have about 20 minutes for this session. It's a short talk session, and my role here is to introduce our next speaker. Professor Kondwani Charles Jambo, he's from Malawi. He's a professor of immunology and infection at the Liverpool School of Tropical Medicine. He's based at the Malawi Liverpool Wellcome Research Program, MLW, where he's the co-theme lead of the clinical and experimental medicine theme. Kondwani, you're welcome.
It's a pleasure to be here. And I would like to thank Prof. Moffat and the team here for inviting me to give this talk. I think it's rare, maybe for Moffat, that there are two Malawians in the same building. So yeah, it's an absolute pleasure. I've been here now for 3 days. My first time in Uganda. It's a beautiful country, and I like it. So what I decided to do is to share with you the story, trying to shrink 5 years of work into 15 minutes. I'll try my best to make sure you don't sleep. And what I've decided to do is just to contextualize this global problem to Malawi, showing you snippets of work we have done over the last couple of years. So for Malawi, those that don't know where Malawi is, that's where Malawi is on the map. And if you look at these numbers for the burden of COVID, is that there were about 335 cases per million people of COVID, about 3.1 deaths per 100,000, and about 26.4% of the population received at least a single dose of the COVID vaccine. And this vaccine was mostly the AstraZeneca vaccine. Early on in the pandemic, in around 2020, March, April time, when now COVID had been declared a pandemic, we decided, me and my team, to be on a journey to try to understand what this new pandemic is doing in our population, and what are some of the things we can do to support our government. And I remember asking my team to say, who wants to do some work with me? At that time, the institution had closed most of the labs, only COVID work was allowed, and people were allowed to go home for about 6 months. If they really wanted to work from home, they would work from home. And I said, anybody who was willing to participate, and the people that I'll show you here in the coming slides are the people that volunteered to participate. And remember, during that time, this is in Malawi, the healthcare system is not the same as in the Western countries. We don't know what this disease is doing. We're hearing people are dying in China, in the UK, in the US. But people volunteered because they wanted to do something for the country. So we did our first serosurveillance study. And this is actually, I'm very proud of this work because it's one of the first studies in Africa. If not the first two, or if not the first actually, in Africa to do serosurveillance for SARS-CoV-2. That was published. We did this in healthcare workers. It was a quick and dirty experiment. What we found was very astonishing at that time. This was like April, between May to July time, 2020. What we found is that there was 12.3% seroprevalence. And what we did is then we took the modeling work that was done in China, looking at the mortality and the cases based on exposure, to estimate what number of deaths and cases we would have in Malawi during that time. Amazingly, the number of cases and deaths that were predicted were way over what we were facing in Malawi. So yes, we can claim that there was not massive testing, but one thing that you know in a lot of African populations is that when people are dying, you know. because the graveyards will tell you that something is happening. So the numbers could not reflect what was actually happening. And I remember my colleagues telling me to say, no, we don't believe your data, we don't believe what you're saying. You can imagine after spending a lot of time sacrificing and working with others to do this, they tell you, your colleagues in your own institution tell you they don't believe it. We said, it's okay, fine. We'll go ahead. And this is what we produced. So the lady on the slide there is Dr. Mara Chibwana. She volunteered with me during that time in 2020. Now she's doing her DPhil at Oxford. She's in the second year on a Lord's scholarship. So sacrifice and hard work pays off eventually. Then what we did is we said, fine, what else can we do to try to prove this? We went and to the blood donors. And what we did is we did a study that I'm also very proud of, because we took samples from 2020 to 2021, going backwards in time from January 2020 to all the way to July 2021. And what we find is that we were looking for surveillance SARS-CoV-2 measuring RBD. The orange line shows you seroprevalence, and the blue line were the national COVID-19 cases. What you clearly see is that between January and May, when there were low cases in Malawi, we don't find really evidence of these antibodies in the blood donors across the country. But you can clearly see over time you start to accumulate cases, and seroprevalence started to go up. I'll show you the waves that we had in Malawi in the next slides. But at this point came a time in around December of 2020, 2021, we had the beta variant. I'm not sure if Uganda had the beta variant. I think beta variant was Malawi, South Africa, Zambia, Zimbabwe. It was a nasty variant at the time, because all of a sudden people started now realizing that there's actually COVID. Before all this, people were reluctant to say, no, I think this is not for us. And when people started dying, including, remember, during that time, we lost 2, if not 3 cabinet ministers. So it was really a huge time for the country. And you can clearly see the jump in seroprevalence to over 60s. And as we continue to follow this up, you see that by the time we reached July 2021, before the Delta variant, we were in the 80s. And you can see from the maps there, we did this in 3 different cities. Malawi has 3 cities. And then in a rural area. And the rural area had less SARS-CoV-2 seroprevalence compared to the urban areas. While doing this, the MOW is next to a hospital. It's next to the biggest hospital in Malawi, within the same compound. So as they were hospitalizing people with severe COVID, we decided to conduct a study to understand what were the immunological responses associated with severe COVID in our setting. And for the sake of time, I'll just get a snippet of this study. What we did is, part of the things we collected was nasal lining fluid from these individuals when they were severely ill in the hospital. Some of them died, some of them survived. And what we did is that we had a group of health controls. We had people that were PCR positive for COVID-19, but we also had a group that was PCR negative, but they were IgG positive. In other words, they had antibodies as evidence of having been exposed to SARS-CoV-2, and then obviously a severe acute respiratory illness group that were neither PCR positive for COVID or IgG and or IgG negative. In other words, they were not COVID patients. When we did this analysis, we actually could see that the 2 groups that were suspected of COVID, despite some of them being PCR negative, they clustered in one group. And this was important because at the time in Malawi, they were only able to give dexamethasone to individuals that were confirmed to be PCR positive for COVID. And what I will tell you that sadly, when we go back in the study, when we finish doing the study, what was very clear is that the group that were PCR negative but IgG positive, that did not receive dexamethasone, the mortality was higher than the other group. In other words, the mechanism we were using to screen these individuals to put them on treatment or not did not benefit because they were misclassified. This is just showing you a choreogram of the kind of cytokines we looked at. Just pay attention to the middle parts of this data, which you can see the PCR confirmed COVID-19 looks similar to the PCR negative IgG positive SARS, but very different to the other group, which were the non-COVID SARS. So we were able to see at this point that what was really predominating in this nasal lining fluid was a chemokine and neutrophil dominated response in this severe COVID that was different from SARS. But the PCR diagnosis at that time, because some of these people would come to the hospital late. So they would come when the PCR positivity had become negative, and then they'll be misclassified and given the wrong care. So from this, we have gone on to do another study in an autopsy study, where we were able to show something interesting in that the severe COVID presentation in our setting is different from the West, and even in the Brazilian population. So what we did is that we did a spatially resolved single-cell atlas, and what we do here that I'm showing you in the first slide is just an example of a stain of the tissue samples. These were lung samples from autopsy, clearly showing you the difference between the COVID patient and the lower respiratory tract disease that was not non-COVID. What we noticed is that if you go to figure B, the pathology seemed to be driven mostly in COVID by a macrophage-driven pathway compared to the lower respiratory tract disease that was really driven by neutrophils in this setting. If you look at the autopsies in the West, what you find is that actually our autopsies were showing a unique macrophage-driven pathology, unlike in the West where it was mostly driven by neutrophils. In other words, if we were trying to do an adjunctive therapy, a host-directed therapy to target neutrophils that worked in the West to come and use it in Malawi, the likelihood that we could not have achieved what we wanted to achieve. The pathology would have still continued because it was a different pathology altogether. So this was very important at this time, to try to study these things in real time in the right settings. Then one other thing we did, we realized that as time passed, we had the original variant, we had the beta variant, delta variant, and Omicrons. We started seeing that, yes, the cases were there, but the number of severe cases was reducing significantly. So we did a study to try to understand the symptoms across time. So we did a study from January 2021, August 2020 to around June, if not July 2022, looking at the different waves and then comparing the symptoms people present with across each wave. What we see here is that when you look at the pre-Omicron era compared to the Omicron era, the number of symptoms they are presenting with was very different. But the definition of what a clinically COVID would be did not change according to WHO definitions. But you could see that wave after wave, these things are changing, and what we would notice is that in the Omicron wave, mostly people are presenting with fever. While in the pre-Omicron waves, you could have cough, fatigue, headaches, and abdominal pain, which was not the case in the Omicron era. So then we went ahead to do another study, a surveillance study across Malawi, to really try to see why this Omicron variant was not causing severe disease. And what we see in this population, I just want to show you here, I told you already, Malawi's population was about 23% was vaccinated. And what we see is that there was very high seroprevalence across the country, but really the number of cases was high, but the hospitalizations and death were low. Suggesting that actually natural immunity itself could be playing a role in creating this picture of having low disease but high cases. We then went on a step further to go in deeper understanding of the immunology. I like this example. We did a study where we are following people up for a year, and in the follow-up we found people that eventually got incidental COVID, and then we've continued to follow them up. What you see, we measured both spike binding antibodies, RBD binding antibodies, neutralization to the original variant as well as to beta variant. What this is showing you is that, and all these individuals were recruited after they had been infected with SARS-CoV-2 previously. And what you see that the time they had a reinfection was the time when they had low levels of beta variant neutralization, and also irrespective of them having high antibody titers, for example, in the female participant, clearly highlighting that neutralization was important. When we then further on to look at the people that were then vaccinated with an AstraZeneca vaccine when they had been previously infected, the hybrid immunity phenomena, what you see that yes, hybrid immunity was also evident using the AstraZeneca vaccine in our population. That's figure B. We also were able to see that there was cross neutralizing breadth after vaccination when people had had a previous infection. Then we went on a step further to try to understand what is the longevity of this hybrid immunity, because that was a very important question that had been answered in other populations, but not in a population like ours, also not with the AstraZeneca vaccine. Most of the work you see in literature is usually with the mRNA vaccines. So we really decided to generate a lot of evidence on the use of this AstraZeneca vaccine, which is an adenovirus, because we know that a lot of the other upcoming vaccines that are non-COVID related are also using these adenovirus backbones. And what we're able to see is that there was really consistent maintenance of this hybrid immunity over time. We looked at different responses against different variants, and we could see a similar picture. One thing that we found was very important is that when we used nucleocapsid protein, which really wanes very fast, we used it as a measure or a proxy of an exposure event or infection. What we found is that throughout this period of a year, about 14 of the 20 individuals we followed up had an evidence that they had a re-exposure event. About 4 of them had 2 exposure events within that period. And then what we looked at is to see what is the effect of this re-exposure event on the neutralization breadth as well as the binding antibody titers. And what we could see that every time there's an exposure event, there was an increase in these antibodies. In other words, what is happening is that this hybrid immunity is being maintained over a long period of time because of re-exposure to the virus, which is something that we think is continuing ongoing because COVID is still here. But what it's doing, why people are not suffering from severe disease, is because actually what the infections are doing is they're boosting the immunity of the people. In the case, this is a population that is hugely under-vaccinated. When you look at the neutralization breadth from these plots, you can clearly see that apart from the Omicron variant, which was slightly decreased, but all the variants previously were properly neutralized above 90% neutralization. So in other words, hybrid immunity in adults who have received the adeno-based virus vaccine can last for at least a year, and re-exposure to non-severe SARS-CoV-2 infections contribute to maintenance of hybrid immunity. Lastly, I want to show you some piece of work. This is preliminary data, but which we are doing using lung samples from healthy individuals that have been either infected or vaccinated. One of the things we're trying to address is we use neutralization antibodies against SARS-CoV-2 as a surrogate of protection. But we really do not understand how that protection happens at the site of disease, which is the lung. The site of disease is not the blood. So what we wanted to understand is what is the link between the antibody responses, the T-cell responses in the lung with what we measure in the blood, which what most people have measured. So in this case, we, in figure A, just showing you flow cytometry plots, showing you the response in bronchoalveolar lavage to nucleocapsid and what type spike, looking at interferon gamma and TNF. Then in figure B, you see nucleocapsid protein, and in figure, and then the what type spike. This is looking at CD4 T-cell responses based on TNF and interferon gamma response. Clearly, you see more antigen-specific T-cells against nucleocapsid or even what type spike in your lung compared to what you see in your blood. If you look at antibody levels, we also measured antibody levels in the bronchoalveolar lavage fluid and blood in the serum. We're able to find these antibodies, both nucleocapsid, what type spike, and even antibodies against Omicron. And Omicron was slightly lower in both the bronchoalveolar lavage and in the blood. When we do a correlagram of this analysis, you could clearly see that there's a very strong relationship between the bronchoalveolar lavage IgG levels and the blood IgG levels. It's also true if you look at IgA. There's a strong relationship, what you find in your blood and what you find in your lung. There's also a slightly weaker but important relationship between the T-cell response in both the blood and in your lung. And this really gave us this hint that it makes a lot of sense why when we measure parameters in blood, specifically for SARS-CoV-2, it's really a surrogate of protection to what happens in the lung. What I've not shown you here is several pieces of work that we show that there's actually a poor relationship between what you find in the upper respiratory tract and what you find in your lung, what you find in your upper respiratory tract, what you find in your blood, highlighting why people can have infections but not suffer from disease. So in summary, high SARS-CoV-2 seroprevalence but low severe outcomes in Malawi. That's what I've shown you. I've also shown you that there's a different clinical presentation of COVID-19 in Malawi compared to the high-income populations. I've also showed you that adenovirus vaccines in the context of hybrid immunity also induce robust and durable cross-reactive antibody immunity. And lastly, that systemic immune responses to SARS-CoV-2 are a surrogate of potential protective response at the site of disease, in this case, the lung. This work could not have been possible without the dedication of the colleagues that are listed on these acknowledgement slides. Like I told about Mara already, she's doing a PhD now at Oxford. Jonathan is about to complete a PhD with me. Upendo just started a PhD in Malawi in my group with me as well. Gloria is on a second year of her PhD now. Memory is about to embark on a PhD journey, and James is in about over a year into his PhD. So yeah, so I'm thankful to be given this opportunity to present, and also just to showcase that science is better when you add training into it. Thank you so much.
Professor, thank you very much for your presentation. I think we have time for 1 or 2 questions, and I'm going to have to ask you one question. Yes, I'm seeking clarification around your hybrid immunity. You mentioned that it's durable. My clarification is that after just the prime dose, or you considered participants that were fully vaccinated, since you were using AstraZeneca? Had they received both? Yeah, and then I think we can have 1 or 2 questions from the audience. Yes, yes, please. Yeah.
Thank you. Thank you very much for the presentation. So my question is regarding one of the charts you showed, showing that there were no SARS-CoV viruses prior to when the disease was declared. So that's around January of 2020. And there's this hypothesis that probably why we had less severe outcomes in many African countries, probably as a result of cross-reactivity from other coronaviruses that are common in the population. But I don't know if why that was not, or why, I don't know if you've tested other coronaviruses in those samples as well to show that we had increases in these viruses different from the SARS-CoV specific virus.
Thank you. I think I'll start with yours before I go to the convener. So, yes, we have measured cross-reactivity to the seasonal coronaviruses. They're endemic in Malawi anyway. We don't find evidence that actually there's huge cross-reactivity. At the same time, we've also measured, I know in other settings, the language is about, it's not only SARS-CoV-2, it's probably malaria. We have done that with malaria. We don't find that cross-reactivity. I think, to me, up to today, the biggest evidence that I see of why we, Africa, probably Malawi in this case, had not have lots of severe disease is the population dynamics. Malawi's average population is 17.9. It was 17.5 years old. And if you look at the data on who were affected the most with SARS-CoV-2 severe disease in Malawi, across the globe, is not that population. So I think, to me, we cannot take away the issue of the population dynamics to explain that. There could be other factors, but I think, to me, that is a huge, huge, huge factor. From all the data we have looked at and analyzed, that's what we think could be the reason. Remind me the question again?
Mine was seeking clarification around the hybrid immunity.
Sorry, before that,
yeah.
You talked about seeing no evidence of infection. So it's not about no evidence of SARS-CoV-2 itself, the virus. What we are saying is that from looking at the population level, we couldn't find the evidence of antibodies against SARS-CoV-2 early on before the pandemic was declared. Yeah.
Okay. Thank you. Now my question, your response to my question.
Yes, what was the question again?
Oh, my question was around the hybrid immunity, where you highlighted.
Thank you.
Yeah.
So, yeah, so the reason why we did these studies is that in Malawi, like probably some of the African countries, all these vaccines were donated. So they would come at a time when they are available, and a lot of people in Malawi only received 1 dose of the vaccine. Yeah? So what we are trying to show is that what would the government do with a limited resource? You're better off giving one dose to everybody else other than giving a full vaccine schedule to a few people. So what the data we are showing you, what we did is that we actually, those individuals had, most of them had only one dose of the vaccine. And to show that as long as there's hybrid immunity, one dose could actually be enough to generate this breadth of response that most likely could also protect against new variants, which up to now we have not been proved wrong, because there is, we know there is a lot of, still a lot of SARS-CoV-2 circulating, but the severe disease in the hospital, you don't see it.
Okay. Thank you, Kondoni. And I think, unless there is another question, okay? Sorry, online, okay? Sorry, we have one online question. Yeah, do you have any information on background adenovirus prior exposure and response to the vaccine? Did you look at pre-existing immunity?
To adenoviruses?
Yes, that's the question.
No, we didn't do that, but we are part of a consortium that will be looking at seroprevalence of adenovirus antibodies to different kinds of adenoviruses. For the sake of, like I said, new vaccines going forward will also be using adenovirus platforms, not just mRNA vaccines. For example, I work on HIV. We're actually in the process right now of testing an HIV vaccine in Zimbabwe and South Africa that uses an adenovirus.
Okay, thank you very much. Unless anyone from the audience has another question. If no, okay. Alan, please, that's the last question. Thank you.
All right, thank you. It's a brief one. So the peculiar weak association between the T-cell immune response in blood and lungs, what's your comment on that?
Okay, that's a good question. I think much of that is, it has to be to do with the sensitivity of the assay, because this is an intracellular cytokine assay. Most likely, if we use a different assay like an ELISpot, which is more sensitive than an intracellular cytokine assay, probably would have a much more stronger relationship. But that tells us to have a relationship between blood responses and lung responses to any response at all is a very rare phenomenon. I work also on TB and HIV. You don't find that kind of relationship. So yeah, so it tells us they must be doing something as well in the lung, these cells.
Thank you very much, Professor, to you and your team. Another round of applause. Yeah, thank you.
And yes, please allow me to add my thanks. That was a very interesting presentation. Now we're moving on to the first of our panel discussions. It's on community engagement. We're going to be focusing on key wins, challenges, and opportunities for research. This session is very kindly being chaired by Ms. Daisy Oya. And if I could request the panelists to come and take their seats as we start the panel. I hope you all know who you are. Ms. Nitha Morar, Ms. Manju Chatani Gada, Flavia Zalwango, and Father Katabazi Emmanuel, please. Thank you.
Hello, good afternoon, colleagues and friends. Good afternoon to the distinguished heads of MRC, UVRI, and the London School, and conference chairs, and the heads of departments, and all the distinguished researchers that have been sharing the research with us, as well as all the other people working in this field. Good afternoon, and we are so pleased to be able to have this very nice and very long opportunity to share some of the experiences that we've had as people working in the civil society and community engagement space for many years. So my name is Daisy, and I work with AVAC under the Research Engagement Program. And the first thing that I wanted to say is that community engagement is a pillar of success in research. Yeah, we have come a long way from where we were, and more community engagement is becoming embedded in the clinical research space, as well as in the rollout of interventions. Communities have very deep and holistic knowledge of their contexts. Communities know what strategies are acceptable, but they are also aware of what is less likely to be accepted. Even if to us it looks very good on paper, communities can help us unpack that. With true and long-term community engagement, we can co-create approaches that serve our research and development goals, and also develop strategies that are more likely to be accepted. And I was quite fascinated to hear Professor Julius Lutwama talking about what a difference community engagement has made in terms of disease surveillance in Uganda, and I think it applies elsewhere. On the other hand, we would say community engagement that is either not done or done poorly can result in a lot of unwanted consequences. These include misinformation, it includes harm to people, to participants, and even unplanned stoppages of well-designed and well-meaning research. And we do have examples of this. And that's why we consider community engagement to be both a science and an art. So we have seen that currently we have many different emerging health crises, such as COVID, Ebola, Mpox, and even Marburg. And all these will need community engagement in terms of the health response. But we have also seen that we have politically driven crises, like the one we are living through right now, where lots of projects, research, rollout, and so on are being defunded and stopped literally with a stroke of a pen. So more than ever, we need community engagement to help us to co-design a way forward so that we are responding to the health challenges that we have. So I'm going to introduce our panelists, and our panelists have combined, they have decades of experience working with communities. They've worked in primary healthcare settings, in HIV vaccine clinical research and other disease areas as well, in product introduction, and in research advocacy. So we'll hear a little bit more about some of the successful approaches to community engagement and some of the lessons we've learned as well. And we would really love a lot of interaction in this session, and we have actually allocated a lot of time for that. So we will not be just doing the talking, but we will be looking to you as the delegates in this conference to really work, also speak out and work with us in the spirit of community engagement. So we hope to come out of this session with lots of refreshed or new knowledge, and some of the strategies that work, best practices,
so that that will help us, build more and stronger partnerships with communities as we navigate the world, which is now a world of syndemics more than single diseases. Yeah, so it's now my pleasure to introduce our panelists, and I think I'll start on my right. Flavia Zalwango is a social scientist with experience in community engagement and involvement. She's currently with UVRI and is working on the Vanguard project. Flavia is actually a PhD student, and she's looking at the potential of risk communication and community engagement to enhance vaccine uptake in communities experiencing intersectional vulnerability in Uganda. Next to Flavia is Nitha. Nitha Morar is a senior research manager at MRC, South African Medical Research Council. She's been part of many research clinical trials, including HIV, COVID, as well as others. And she conducts social science research and community engagement. And Nitha is also a GPP champion, good participatory practice. On my immediate left is Winfred Naziwa. Winfred is an ethicist, and she heads research and compliance and quality assurance, the research compliance and quality assurance unit at the UNCST, Uganda National Council for Science and Technology. Winfred has more than 10 years of experience in research oversight and protection of research participants. She's also pursuing her PhD, in particular on research ethics. Next to Winfred is Father Emmanuel Katabazi, who is a priest of Masaka Diocese with headquarters in Masaka District. Father Emmanuel has served as diocesan head health coordinator for almost 2 decades. He is also the CEO of St. Joseph Hospital in Kitovu. Father Emmanuel is also the CAB chairperson at MRC Masaka Station. Last but not least is my colleague, Manju Chatanigada. She is the Director for Capacity Strengthening and Partnerships at AVAC and a longtime research advocate, and she mobilizes civil society around HIV prevention research through rollout. So Manju leads the Advocacy Fellows program that ensures that civil society champions have the knowledge and skills to lead evidence-based policy change throughout the region. Manju's passion is actually women, prevention in women, and she has been advocating for the inclusion of women in HIV prevention research within a rights-based framework, and Manju will touch a little bit more about that as we go forward. So without further ado, I'm going to ask the panelists a few questions, one question each actually, and then we will move to an engagement with yourselves and ourselves. Question and answer, comments, we welcome them all. And then we are going to hopefully leave this session with a kind of a way forward, a bit of hope. We don't want to concentrate so much on the gloom that is enveloping a lot of us, but we want to come out while recognizing it, but also coming up with some ways forward, some positive ways forward where we can grow and be stronger together. Okay, so my first question actually is directed at Flavia. So you're a social scientist, and we've seen how the US government directives has caused a lot of upheaval around the world, and even defunded research and even primary prevention in our countries and around the world. So as we know, trust
is very key when it comes to community engagement. And the question is, from your work as a social scientist, how are we going to rebuild the trust with communities? And what are some of the ways that you have experience with in terms of co-creating messaging with communities in order to strengthen prevention of HIV and other diseases? Thank you, Flavia.
Thank you so much, Daisy. Good afternoon, ladies and gentlemen. With regard to rebuilding trust in the communities, I think we'll need to spend a bit of time with our communities, whether new communities or old communities, reflect on our past successes, and also reflect on those factors which could have hindered success in the past. It is important for us to engage communities early enough, give them time to ask the necessary questions, but also give them the right information at the right time. The community engagement process should also be continuous. It's not enough to go in the beginning, disappear, or do whatever you have to do, and then you come again at the end to disseminate results. I think we need to engage continuously. We need consistent and combined efforts. We need to work with the different teams, leverage on the partnerships, so that we can draw on each other's strength in order to engage the communities. You'll agree with me that many of us are working in communities where other organizations are also working, and there's a lot of duplication of effort. So I think we need to work together and see how we can get the best out of those partnerships. We need genuine engagement. What have we done to reach out to those people whose voices are not heard? The disabled, prisoners, the children and young people. Many times we reach out to the key stakeholders or the key gatekeepers, and we forget to engage certain categories of people who are also key in our work. And that leads me to the next key point about leadership in the community. When we identify the leaders to work with, because usually they are the sources of information and the sources of misinformation and fake news. And sometimes these people are negative about some of the work we do or the information that we share, like vaccines. We've had leaders who are spreading negative information. So we need to be careful how we engage with the leaders so that they can help us to drive our agenda, but also they should be able to help us to understand the local knowledge, the local construction of the concepts that we're trying to explore in the community. We need to understand the layers of power and influence in the community, and if we've not done that enough, then it is the time to go back. It's never too late. We also need to understand who else can make a difference in the community. Where are the men? In some of the communities, the men are so busy. They're too busy to participate in the different programs. In Kome, for example, we had to look out for the football clubs, because these are powerful in mobilizing the fisher folk. We had to look out for people who are running the drug shops in Namayingo. People have to engage with one of the EPI meetings, and we're able to understand the kind of community engagement that we need to start with before they roll out the vaccine. So we need to engage with people at all times. Yeah, so the CAB members are also key in our work. and especially where we're working with people facing intersecting vulnerabilities. The CAB members understand the communities better, so we need to work with them and also bring them on board so that together we can navigate through the community and also understand their concerns. So with regard to co-creation, I think we need to continue participating with the community instead of just dictating to them what they need to do. We need to use a range of methods, innovative methods, that are also relevant to these groups. They should also be relatable. Where we need to use music, dance, and drama, I think we need to do that. Where we need to use peers, especially with the young people, I think we need to be open to that, and also reflect on the channels that we use, radio, social media, the meetings that happen in the community, even when we are not there. In one of the communities, when we asked the LC3 chairman if they actually do community engagement meetings and talk about vaccination, and he said they never happen because he thinks that people must be given tea and soda and that kind of thing. He says we don't have that kind of money. But we need to discuss with the communities and let them know that we can actually go in for cheaper methods of engaging communities. Yeah, so as a call to action, I think CEI should be a deliberate process. We should not just do it because the funders require us to do it. We should have a clear goal. We need to have a clear plan and also reflect on the guidelines that had been put in place by UNCST and other collaborators. Yeah, thank you so much.
Thank you so much, Flavia. Yeah, that was rich. And so if you have any comments or questions for Flavia, hold them, write them down. So I'm going to turn to Winfred, who is an ethicist. And the question to Winfred is around ethics. So we know that ethics is actually a non-negotiable in research on people. And yet we have witnessed research programs that have just been stopped in their tracks, like overnight, because of the various executive orders coming from the White House. So my question to you, Winfred, does this abrupt stoppage of trials constitute a breach of ethics based on your ethical training and knowledge?
Okay, thank you, Daisy, and good afternoon, everyone. Yeah, so before I go to Daisy's question, whether a stoppage of research is an ethical breach or not, I would like to meander a little bit and indicate that research is important, more so clinical research for human progress. Though I work for a regulatory body that oversees research, I know I earn a salary being one of the people that oversee research, and that's not the reason why I'm saying it is important, but it is indeed important for human progress. And in the 2 days we've been here, we've seen the outputs of research. We've seen the importance of research. So research is key. It is vital for us to progress as a society. So the decision to stop research and not only clinical trials carries significant ethical considerations, and there are key ethical principles and responsibilities that funders and sponsors must, and please I'm emphasizing must, uphold when making this difficult decision. It is a difficult decision, but there are things that they need to uphold as they make such a decision. So I want to make it clear that stopping a clinical trial or even any other research is not inherently an ethical breach. I've looked at some of the informed consent documents where research participants are told instances when research could be stopped or terminated. So there are legitimate and ethical reasons why research could be halted by a sponsor. For instance, if it poses risk to the research participants, if there are safety concerns, if, for example, the research is futile. We've seen data safety and monitoring boards recommend stoppage of a clinical trial. There are instances where there are ethical issues that have risen, and research ethics committees recommend stoppage. So there are reasons where it is acceptable to stop a study, and there is no unethical breach. So to answer Daisy's question, when does stopping a trial or research constitute an ethical breach, or when may the stoppage cross the ethical boundaries? There are boundaries that shouldn't be stopped, but when does it cross the ethical boundaries? So ethical breaches arise when clinical trials are stopped for reasons that compromise the research participants' safety, their well-being, if it compromises research integrity and scientific integrity, if there is lack of transparency, or when the research participants are left unsupported. And there are a few cases or reasons that I can highlight. I'm not saying these are the only ones, but there are a number of cases that I can raise. So if there are financial reasons, mainly if the sponsor decides to stop a trial or research simply because it is too costly, fear of the negative results, or the outcome may undermine the sponsor's commercial interests, that in itself can constitute an ethical breach. If there is lack of ethical oversight, we know that research ethics committees are put in place to oversee research, to ensure that the research participants are well protected. So a decision to halt any research study made without consulting the research ethics committees, that would constitute an ethical breach because it could violate protocols or procedures designed to protect the research participants and ensure scientific rigor. Then the other is failure to inform participants. And I don't know if this happened during the stoppages that have just happened. So we need to be transparent. And Flavia hinted about transparency, which is key in the research processes. So it is critical that participants are informed about the reasons for stopping the research. They are consulted in a reasonable manner before the research is stopped. Then if there is no adequate and clear justification, there is no scientific reason why you're stopping a study, then that constitutes an ethical breach. Then also disregarding research participants' safety and well-being. If there isn't proper care and follow-up of the research participants enrolled, if participants are left without proper alternatives, so if you're to stop a research study, can you give them alternatives? You know, you refer them to something else from the study that you are doing. So we need to care for the participants. Then the duty of the sponsor to the research community. So the scientific community has a right to understand the reasons behind the stoppage. I don't know if this was done for the recent stoppages. Did we consult with our communities what we intend to do? Was there transparency? Yeah. So all those would institute or contribute to ethical breaches. So although funders and sponsors may have the right to withdraw financial support for a study due to concerns, it could be feasibility, it could be ethics or safety, it is crucial that they do it with a careful consideration of the ethical ramification that such a decision will bring to the participants, but also to the research communities. And decision to stop clinical research should involve consultation with the key stakeholders, with the communities, with the scientific committees, with the research ethics committees that gave approval for these studies to go on, with the regulatory bodies to ensure that the action is justified and the impact on our research participants that bear the burden of research is minimized. Also, if a clinical trial is stopped, participants should be given clear communication and supported and alternative care options where applicable. And Daisy, just to summarize, I know I've said a lot, but research sponsors have an ethical duty to prioritize the well-being of the research participants, maintain transparency, and ensure the integrity of the scientific processes. There should be public trust and fairness. So failure to meet these obligations when stopping clinical trial or clinical research indeed is an ethical breach. Thank you.
Well, thank you so much for that. And I think among some of us sitting here are researchers in some of these trials that were stopped, and maybe you can ask yourselves the questions that Winfred has posed. Right. Thank you so much, Winfred. We are going to turn to Neetha, who works for the South African Medical Research Council and has been pushing good participatory practice in different studies. And my question to you, Neetha, is we have a shifting research landscape, I don't need to say more. And my question is, how has the good participatory practice evolved? Community engagement, is it changing? Is it staying the same? Because our world has changed and it's changing. Yeah, thank you.
Hi, good afternoon, everyone. Hope you had a good lunch, and thank you to the organizers for inviting us and having community engagement as a topic on this program. So kudos to you. So just a little about good participatory practices. It was developed in 2007 and then revised in 2011, and of course we're in 2025, and a lot has happened. So the best thing in any work that we do is change is a constant. So the issue around good participatory practices, what is really important is understanding the principles which Winfred, together with Flavia, have alluded to, and these include things like having scientific integrity, ensuring there's transparency and trust, there's mutual understanding, and very importantly, what has been highlighted in the last month and a half with the US presidential order is the issues around social value, human rights, and how do we then, in community engagement, put that into practice? So I'm very fortunate that I'm here actually in Uganda, and also my first is that I've been part of the PrepVac trial, which I'm going to use as a case study to highlight the implementation of not only excellent social science studies that was alluded to by Flavia, but also some of the ethical practices and community engagement practices that was implemented. And on that note, I'm actually going to pause and ask all the PrepVac colleagues to please stand up, because you are actually the implementers of community engagement practice in the field. So I'm going to indulge the chair and the panel. So if the PrepVac team, whoever you are, please stand up, especially the CAB members. And Eugene, I'll start with you. And I'm not shy. So the reason why I want to call out the PrepVac members who are here, and it's just fortunate they're here, because you would have heard yesterday that it's not only an African-led consortium, but what the PrepVac trial did is that we have on our panel Father Emmanuel, who is part of the CAB in the PrepVac trial, and together with him and the colleagues, they were all included from 2 years ago on the investigators meeting, implementing good participatory practices, good community engagement practices, and that included them sharing some of the structural and social issues they had with regard to research. They were facing as communities, like poverty, lack of access to medication, poor housing, poor sanitation. And in addition to that, what the PrepVac team did after listening to us advocating and after listening to the CAB members, where they were informed that the trial was so complex that the tools they shared with us as sponsors was inadequate. Of course, as usual, there's never money. But because the community members advocated so well, the sponsors found a video, developed a video, together with the community engagement practitioners, the staff, and the CAB members, so that this study could be explained well. In addition to that, when the dissemination came, and this is a research dissemination conference, we had the PrepFac interim results shared in December last year, and by then, because the CAB members were part of our monthly conference calls participating, of course Eugene and Sheena and others would join us and guide us along the way, but it was a lot of guidance that we received from the CAB members, actually educating us researchers about how things can be communicated with community engagement. And then the cherry on the top, which is my favorite, is that when the results came out, many of you used the word disappointing. Yes, it was not what we wanted, but what was really great with the support of sponsors and the partners is that we were able to ensure that the results that were given to our study participants at all 4 sites and to the CAB members well before it was presented at the International IS Conference. And for that, we had to really push boundaries and ensure that there's community engagement in practice. And we were very fortunate that the levels of Sheena and Eugene, as you know, the trial was run, African-led consortium in Uganda, that while they were hesitant, they listened to us. And people like Vincent and myself and Father Emmanuel, we were able to really work hard, and we then sat on conference calls to stakeholders, regulators like SAPRA, having CWG members, CAB members as part of the panel. This included our CAB members speaking to journalists back in the day and explaining their views on the results. So in summary, I'm not the GPP champion actually. The champions are amongst yourselves and the audience, because the PrepFac trial is just one example of implementing ethical social science studies, and a lot of these publications are out. Thank you.
Thank you so much, Nitha. Yeah, I agree. PrepFac was, I think, a GPP success. Yeah. Thank you. Nitha mentioned Father Emmanuel, and that's whom I'm going to turn to next.
Yes.
So, Father Emmanuel, we know that faith leaders have a very powerful role in terms of shaping and supporting society and also communities, right? And so from your experience, because I know you have over 2 decades working in communities and also as part of research programs, what are some of the lessons you would share with researchers for engaging communities in ways that are culturally as well as spiritually sensitive, so that the engagement actually is successful? Thank you.
Thank you so much. I will request that you allow me to send my message to the researchers using parables like our Lord Jesus Christ did. Whenever he was to put across a point, he could begin with a story. And that is me, so bear with me, scientists and other people. But this time, I just want to use actual incidences, what happened to me, for you to for you to get the message I'm trying to deliver. One day, I was invited by MRC. I think that was a dissemination about Van Gandhi study. I think that was it. So I think it was a review, and I met Dr. Musoba Nelson, and he invited me for a conference which was to discuss the research agenda. And I was happy that I was going to interact with the scientists. I went. But as I was entering the room where the people had gathered, I could see people looking at me with a lot of skepticism. I don't know. People are saying, where is he going? Maybe he's lost. So I proceeded to the table where they were doing registration. And the lady told me, oh, Reverend, I have seen reverends going the other side, maybe. I told her, that I was invited by Dr. Msova, and here he is. So I was rescued by Dr. Msova, and I was let in. But what did I learn from this? It seems at times we may talk about a lot about community engagement and involvement, but it's not yet on our hearts. As scientists, to engage the community, you need to respect them, to have confidence that they can also contribute. I don't know whether I made a wrong judgment, but that's what I saw, and that is what I'm sharing with you. And I will just use those incidents that happened to me to put across a message for you to be sensitive when you are dealing with the community of different types. Then another incident was in Rakai, like 10 years ago. Again, there was a research that was conducted about family planning. And they invited religious leaders of different denominations. So time came to read out the results. And the presenter was very, very categorical. He said, when we went around, we discovered that many people are taking new methods of family planning because of their faith. So he made a conclusion. I think the Catholic Church in this area has to do something. And it actually became very confrontational. Say, the problem is with you people. You change that teaching, it is, to be sincere with you, most of the Catholic priests that were there were somehow offended. But I wish that the scientists devise ways of communicating with the people that does not really embarrass them. Once you begin judging someone, even the interest goes. But later on we agreed that we can encourage our facilities even maybe to refer patients to the public facilities. And that was, later on it was concluded amicably. But I felt there was something lacking. As we do research, I think we also need a component of soft skills in communicating. For me, that one is very, very important. Then the third incident, which happened here in MRC. I'm not embarrassing you. We had again, I'm so lucky that I've always been invited. We had a conference again. I think that is the Van Gundy study. And they invited many people from Chamulibwa, including CAB members. It was a good number. And when we started the conference, these people felt that there was something missing. And what was that? There was no prayer for anything, at any moment. So when they came out, they said, Father, you tell those people, let them be, I think for us, we are used to praying each time we are beginning any activity. And I remember when I got the chance, I even communicated to the gathering that was there. So that is something very simple, but when somebody goes back and is asked, what struck you at the conference? Such a person who is notoriously religious will say, at the political parties we say prayers, but there we never said anything. As scientists, okay, it is your choice, but I know some of you believe. But when you are engaging the community, please be sensitive to what they do, because prayer is becoming like part of the culture among the people. Yes, I think that is very, 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 very important. And but at the same time, we never wanted that we focus only on religious leaders. There are so many constituencies that need to be fully engaged. Religious leaders could only contribute maybe 10%. There's so many others. Let us focus even on social media. There's so many influencers. I was reading a text on my WhatsApp, and they're saying these small girls like Gashumba have so many followers. We never share information, enough information to engage the community in that way. I feel something has to be done and engage the various constituencies. Otherwise, people are actually snatching the chance. Many herbalists are able to do it. They are able to market what they have researched on, even without publishing papers. They don't publish, but they're very good. They disseminate information to everybody. But people with a lot of information, well researched, I don't know, people know very little about what we have done. But let us involve everybody. I thank you.
Thank you so much, Father Emmanuel. That's very important tips. Hold your questions. We are going to the final part of this particular round, and then we are going to open it up. So Manju, you have worked with civil society for, many, many years, yeah? And I wanted to ask you, from your experience, what's the role of civil society in community engagement efforts? Because there's that distinction, civil society, community. And especially now with the kind of shrinking budgets and the kind of political landscape that is unfolding and has unfolded. Please elaborate for us, if you may. Thank you.
Thanks, Daisy. First of all, I'm really delighted to be here, and I want to thank the conference organizers for recognizing the role of civil society, not only in talking about community engagement, but being here and being part of understanding how research is progressing. With the USAID cuts, civil society organizations across the world have been affected. Over 100,000 jobs have been lost, and every day there are more. And this has affected, of course, research. It has affected implementing organizations, and it has affected these thousands and thousands of advocates who have taken it upon themselves to really be champions for science, for evidence-based policy, and for ensuring that the voices of community leads the research agenda and the way implementation happens. So this hit on civil society affects how research happens as well. And just using that frame, I want to remind us about the important role that civil society does play in research, and especially in community engagement. Because you're right, Daisy, let us not confuse the the importance of direct community engagement, but also the role of civil society in really lifting those voices and ensuring they go beyond retention and recruitment and being part of a trial, but really affect national policy. So the role of civil society is important as bridge makers between communities and researchers, as trusted intermediaries, really pushing for two-way dialogue, which builds trust. In advocating for community priorities, amplifying those community voices and what they consider as most important to study, what affects their life more. I mean, we may go in and think, HIV is the most important thing for you right now, but actually, the babies are dying of malaria. That's where it has to start. How does the research that we want to do really identify the gaps communities themselves are seeing? And this is where civil society will continue to do that in several platforms and really force the research enterprise to be accountable for the research they do and why this is important at this moment in time with funding restraints. Civil society take it upon themselves not to advocate only for themselves, for the broader community. And this moment, I'm actually going to take the liberty of talking about a lawsuit that my organization, AVAC, along with other organizations, have taken on against the US government, really talking about the illegality of the cuts that the USAID, that have been made in USAID on pausing and suspending contracts. And to be clear, we did this for the field and not for our own organization because it has destroyed foreign aid right now, and it will really affect how foreign aid happens going forward. Another thing civil society does is be a little bit of a watchdog in ensuring that ethical standards are followed, in really holding researchers accountable for all those ethical promises that they hold themselves to. What we saw in COVID was how important the role of civil society was in countering misinformation. We saw anti-vaccine sentiment. We still see it now. It's affecting immunization records. It's affecting how communities have stopped taking their children to standard vaccines. And I fear with some of the changes that is happening in the US health infrastructure, we're going to continue to see this. And civil society use media platforms, social media. In every conversation they're at, they stand up to really counter this misinformation. They take on the community leaders who are pushing back on vaccines. Another really important role is translating research into actionable change so that research doesn't remain in peer-reviewed journals that only a few have access to and really find their way into policy change. So the policies in our countries are really led by new research, new learnings, and to ensure that we are pushing that these research findings, just like we've heard from many of the panelists here, are shared with the very communities that helped give this research. Too often, the communities are last to hear about the findings that they help bring forth. Finally, civil society has been really important in mobilizing resources for research, for talking about their priorities when they are in those international forums and ensuring that the bilateral funders, the national governments are hearing what they think is most important. And now with the cuts, research is being gutted and being censored. Ask yourself, who is losing their jobs? Are those community partnerships entering into the conversation about how important they were for research? They are losing their jobs. Who's talking about the participants who have been left stranded by trials who have ended? Who is speaking up for them? And here's where the power of collaboration with civil society is more critical. Researchers and advocates are standing up together to monitor the changes that have been made and the effects they'll have on health research. And now especially we need to make those partnerships stronger in leading protests, in documenting what we're seeing, and looking for innovative ways to make sure that this research happens in a much more sustainable way, and that the basis of decision-making is based on evidence and not the misgivings of some of our decision makers. Thank you, Daisy.
Well, thank you so much, Manju. Also for drawing that distinction between community, civil society, and decision makers. So the time has come when we would like and love to interact with the room. So I trust that you've been recording your questions, and we will take comments, questions, observations, etc. Welcome. We have about 30 minutes for this session.
Thank you, panel discussants. The spread of false and misleading information currently has turned from misinformation to disinformation. That's a trend that is moving towards disinformation. And unfortunately, it's not the common man on the street. It is people that would have expected to pass on the right information. Just to pick your thoughts, that as researchers, is it time for us to think the community engagement involvement strategies, that information? But unfortunately, what we are seeing now is the intentional spread of false information. Thank you.
So thank you very much for your question. And we'd really like people to introduce themselves and tell us where you're from so we can get to know you better. So you're absolutely right. So one of the things about participatory practices is that how do we turn the current guidelines on its head and ensure that they are meeting the needs both legally but also from an information point of view. And so one of the questions I had for myself is, what did we do to inform our community working group members, our civil society, locally, nationally, at ward level, provincial level, African continent level, and what did we do working with African CDC, AMA, AMREF to ensure the messages are going out there? So one of the things we did at SMRC is we've actually gone to each of our CAB groups. We have 6 sites, and we've started communicating and dialoguing with them, and it was actually shocking the misunderstanding they had about President Trump's order. So I think every one of us, we are first individuals, we are first community members, we are first advocates who have to ensure that there's correct information, one. Second, we need to have accountability to the groups that we work with, whether it's our organizations, whether it's civil society, whether it's calling on each other. Manju spoke about support, collaboration. Are we doing that enough? And my short answer is no. I mean, today is what, something of March, and this happened on the 20th of January, and we still yet to have webinars in the African continent, listening to CAB members, listening to the participants about this issue. And the last statement I want to make around ethics is that one of the scientists in South Africa, when the USAID stopped, she did not allow the participants to carry on using the vaginal ring without ethically ensuring that they were informed, they were called in, they were counseled, and this went against the grain of the president's order. So we have to take risks, and we have to ensure that the priorities of the participants are there. And then those messages, by the way, were in New York Times, in Nature, in journal articles. And this was Professor Leila Mansour from Google, if you don't know this. And she took a chance. She lost matrix trial. Thank you.
Thank you. My apologies. I am Ludovico. I'm a research scientist, and I work with the MRC unit.
Thank you very much.
Okay, thank you, Nitha. And you mentioned ethics, and we will also hear from...
Thank you, Daisy, and thank you, Dr. Ludovico, for that question. Just to add on to what has been said, you ended with, should we change the strategies for engaging the communities? And I say yes, we need to change. I have a problem with researchers. When you talk about community engagement, minds run to community advisory boards, to the CAB. Yes, CAB is a very important approach for engaging communities, but it's not the only one. We have a number of approaches that can be used to engage our communities. And I like the panel here. It constitutes some of the approaches that we can use. We can use civil society. We can use the community leaders, and not only faith leaders, cultural leaders. We can use the mass media. We can use a lot of approaches. Can we go beyond the community advisory boards and engage other approaches? As UNCST, there is a guideline that has been put out guidelines on community engagement for research. There are a number of approaches that have been listed in there that researchers can use for engaging communities and effectively engaging communities. Thank you.
Yes, I can add regarding mitigating against misinformation and disinformation. I propose that since we have so many scientists, I beg that you can create a kind of a team doing surveillance on the social media who are able to answer people's questions. I don't know whether it is possible or not, but there is a lot of misinformation on social media. There was a time when people were talking against the humanized rats. A lot was said about the humanized rats, and we as community members, we didn't know that a rat could cost all that much. But when I went to Professor Ponciano, we were in South Africa, I whispered to him, is it true that a rat can cost all that much? He told me, yes. So from that day, I was liberated with information. You know, when you give right information, liberates people. For me, that is very, very important. And I beg that even for other things. At one time again, people were opposing a lot the initiative of the president to make a new vaccine. But when they saw, again, professor and other learned people, they say, oh, this thing could actually be right, could be true. So I just call upon the researchers and the scientists, please bring your guns, bring your information and support the community. We are subjected to so many dangerous information.
Daisy, can I add something?
Absolutely, yes. Thanks.
I love your story and your example. And I mean, I think when we think about disinformation, sometimes we have to ask, where does the confusion start? That it's so easy to fuel disinformation and misinformation. And I love this example of, clinical trial studies that were happening, let's say, 5 to 10 years ago, where they had started using hair samples to look at drug absorption. And of course, there were community members, I'm thinking about a study in Zimbabwe, who were really anxious about the use of hair samples and connected it with magic and nefarious activities, and there was a lot of rumor mongering. And so a really innovative mechanism, intervention, is they introduced tours of the research site with trial participants, but also with community members and community leaders, and walked through all the processes and the lab, and showed them how samples are kept, what is done with them, and really kind of normalized. This is just a regular clinic. These are regular people. This is how it's kept, and it's done in such respectful and confidential ways. And the same with media, who had all sorts of preconceived notions, is actually respect that there might be confusion and bring them into the process, and respect that there might be a confusion that you didn't explain properly. So I think there are a lot of innovative ways to counter disinformation. And the last one I'll say is that it's communication theory. When you have negative messaging, you will spend your whole life trying to correct every error. Instead, flood the zone with accurate information, completely. Everywhere there's negative information, don't look that, no, this is wrong and this is wrong. Just keep on flooding on radio, through social media, through the news, and through those champions like you talked about, Leila Mansour, willing to talk up, because it depends on the messenger. Different communities and different people will only believe a change of a message when it comes from the messenger that they trust.
Amazing. Okay, we have a question on the left there. Thanks.
So I'm Dr. Jane Kenje Kayondo. I was MRC unit staff number 1. I worked with Dan Mulder at the beginning of the program, so we started the program together. I built it up for 10 years, and then I left for WHO, and I think got totally forgotten, so I'm very happy to be here. I like this panel because it is really tackling the realities of research. One reality is the community engagement, because they see the research process as for your benefit. You see it as for their benefit, but they see it as for your benefit. So I think there's always this need to always think what is in it for them, and be very clear, have a strategy, have a budget for making sure that what is in it for them beyond the research is substantial. And I think the second point I want to comment on is this issue of what has happened with Trump. Trump doesn't have any agreements with the research communities. They signed down with you. They didn't sign with Trump. So I don't think we can go around saying, oh, no, it is Trump. We need to find a way of still being able to explain to the community, because they don't have any contract with Trump and they didn't sign down with Trump. Because I think it could actually affect future relationships if we don't handle this properly. So I'm seeing a need for empathy, a need for having some of the resilience skills. Now I work with soft skills, so I'm very sensitive about this. Different ways of communicating, not just the facts, but also the truth behind the facts. Being able to put yourself in their shoes and understand them is going to take a lot of skills that we probably don't traditionally have. So I'm really cautioning against saying it is Trump, it is Trump. Trump did not sign with anyone. It's you and us and the researchers who signed. The pulling out or the winding down has to be done with very, very, very big sensitivity. Otherwise, it's a very, very delicate situation that all of you are in. Thank you so much.
Thank you so much for those remarks, Dr. Jane. So much appreciated. We'll take the next question and tackle it.
Thank you. My name is Femke. I had the Disability Research Group at MRC in Uganda. My question is about involving persons with disabilities. And as a research group, we promote community engagement of persons with disabilities. So we have an advisory group that consists of youth with disabilities and persons with disabilities. And one of the complaints that they often give is that, yes, you've involved us, which is great because you're doing disability research, but we are often left out of other studies or other engagements because we're only seen as a special group that needs to be addressed if it's about us. So I was curious, do you have any experiences of involving persons with disabilities in a community engagement, and how have you succeeded? And I'd like to hear from you. Thank you.
If there's any other question, we will tackle a couple together.
Thank you. I'm just taking the opportunity to ask a question. I'm asking it in my capacity as head of the social determinants of health at the unit. And I thank all of you for this really important panel and all the contributions. I'm obviously a convert when it comes to the importance of community engagement. But I wonder if you could tell us a little bit from your own perspectives. I think we've touched on it a bit, but what does gold standard community engagement look like Femke has just talked about, we engage people with disabilities if the study is about disabilities. And particularly for us who have a population cohort, which means they'll have several studies, we engage them when we're doing that study, and then we maybe pull back a bit. And again, we have a very good and effective community engagement activity in all our sites. But for other studies, is it acceptable just to engage around the time of the study? What does gold standard look like such that they are not just included because they are subjects or participants in a research study? How can we ensure it's a longer term engagement? And while I have the mic, there are 2 online questions. One is a general question to all the panelists. What can be done in case the communities get tired of participating in the research studies? I think that relates a little bit to my one just there. And perhaps to Winnie, are there plans for the UNCST to engage more with local researchers? Thank you.
Thank you so much for those. We're going to take one more and then do a round of responses.
Thank you for everything. My name is Christopher Benan. I'm a journalist. My question is, how do you deal with a community that has little knowledge about science? How do you convince them that this is the right thing?
Allocate the questions. So I think maybe Neetha, you can take the question on the gold standard of community engagement and community fatigue. There are such things as over-researched communities. You're right. In terms of the people with disabilities and how they're included, I'll pass that question to Manju, because she's been working a lot on inclusive research, and perhaps Father Emmanuel can tackle the one of communities with little knowledge about science, and then the other panelists could add if they would like. Yeah, Neetha, Manju, Father Emmanuel.
So the gold standard is us, in simple words. And when I mean that, it's a collaborative process. But to explain it in more specific ways, there's many guidelines. And in fact, Uganda is on the WHO media document this week. And it's quite interesting that we're having this conference because Uganda was shown to do this community engagement program so well collectively, etc. But to answer the question about gold standard is that we should never be going to communities when we have the protocol, one. When we have the idea, that's when we should be going to community, and not just to the CAB. It should include stakeholders, which are ward leaders, including ethics committee members, because they are a community. Often they don't understand necessarily the work we are doing. They are ethicists, and we expect them to make decisions on that. One of the things we've done in South Africa recently, as you all know, we have auditors, we have sponsors visiting us, and we have regulators visiting us. And more, in the last 2 years, we've taken a risk, and we've asked community members, which are CAB members often, to be present when we have the auditors there. And that way, they are not able to only just see the process, but the guests or the external people can interview them. For me, gold standard means the principles. So more importantly now, and I take the point the last speaker spoke about, is not to blame the president, because we accepted this research, and what are we doing from a legal point of view? Are we understanding our agreements, and are we understanding what rights and what protection we put there? But with regard to the gold standard, it must include human rights. It's a key principle. How are we explaining that? It must include good participatory practice training. There's several free online trainings, and we don't do that enough because we have budget constraints. Just like how we get trained for GCP, GPP, pharmacy practice, GCLP, etc. We should all first, researchers need to be trained on GPP, and then the community members. And then the third is, the biggest missing point, and it pains my heart, is we don't have participants speaking about their experiences. And you can have peer educators with ethics approved, because 30 years into HIV trials, we have advocacy of participants who are not sitting amongst us to speak about the consent form, about the product, etc. And I think the last thing I want to say about fatigue is that I'm working in communities now for 3 decades. Started off as a child, naive and really stupid, and they've really made me who I am as community members. But how we avoided fatigue is we did not just do HIV, SAV, and I get bored. We did other things that were interested the community, and they helped teach us things around their skills. They became the chairs of meetings. They ran the sessions, etc. So you can minimize fatigue in that way, but also get involved in their own projects. My pet thing is recycle, repurpose, and reuse, and getting the communities involved in how they can fund for themselves and doing those little projects. But fatigue is an issue that we can deal with. If you look around us, there are many scientists here, CAB members. Father Manuel is doing this over a decade. And how do we keep them motivated? So I'll stop there.
Thank you, Nitha.
Yeah.
Let's go to Manju.
Thank you.
In terms of the inclusion question.
Yeah, I'm really glad you asked this question because I think there's a lot of shared responsibility to go around for the non-inclusivity of people with disabilities. And I'm guilty of not including people with disabilities unless the conversation on the table is, disability. We don't see civil society advocates also seeking out those NGOs and those groups to ensure that as they are advocating for research and new design, that they are doing that. I mean, this is the same issue we had with the inclusion of transgender people, of the inclusion of pregnant women in research. I mean, as an example, in the inclusion of transgender people, and I'm sure it's the same for people with disabilities, is that there was an analysis done of how many studies engaged transgender people, and realized they didn't even ask the question to even be able to report on if they had engaged transgender people or not. And I wonder, in many research studies, do they even ask the question about disabilities? And is it only seen physical disabilities, as opposed to the whole gamut? So I think the responsibility really is across the board. And I mean, if we think about the risk of, research which is not inclusive, it deepens inequities in the communities. It continues to disenfranchise communities that are being affected. And really, it weakens the public health impact of interventions if it's not really comprehensive in the community, in engaging communities. And to be honest, it's a regulatory and ethical failure to not engage those communities. And in terms of interventions, I think that we really have to look for, we really have to leverage the data. I mean, that's what we work with civil society, is really equip them with the evidence so that they can talk about it in informed ways. But I also think it's to look for those research champions to bring it up, just like you have, in these environments, and really look for cross-sector engagement. But as civil society, I know we strive, and I'm really glad you brought it up over here.
Regarding dealing with communities with little knowledge, I can use the image of runners who are running in a group. I don't know how they call it. Is it a relay? Relay, yes. One handles the stick and hands over to another person, and another one continues. I think that is the kind of model we may need. I understand for example, at Masaka, MRC, we can see that knowledge is passed on from the scientists, and also knowledge is passed on from the scientists. There are two types of people at MRC. We have the scientists and the liaison officers. When you hear the liaison officers talking about research, you may think that they are also scientists, because they have been able to understand what goes on. And then the liaison officers also do it very well. They invite the CAB members explained and explained. Some of our club members, like Olivia, who is with us here, they are very knowledgeable about what is going on. They are able to pass on that information. But the missing gap is where to get this information to many people in the community, because the fact is there is little investment done in supporting that link from the club members to the community. And even from the scientists to the community, it is also possible. We could make use of the media, radios, and continuously sensitize people about what we do and what we want to do. This is my belief, and this is my suggestion. Then regarding the gold standard, again, I'm in line with what Nitha has been talking about. We need to do it at all levels. It has to be cascaded down to all levels. Now we have a research dissemination conference here. I was already asking myself, will there be, this is an international dissemination. Will there be a regional dissemination? What about the community level? Shall we have that? That is when we can actually help the people to understand. But we are let down by the resources. And what can we do? We just focus on the key stakeholders and share information, expecting that they will be able to pass on the information. I thank you.
Yeah, there was a question to the UNCST, plans for UNCST to engage with the local researchers. This is an interesting question. I thought UNCST and regulators are part of the stakeholders that researchers should engage. Yeah, but anyway, just to indicate how UNCST has engaged researchers, I think researchers are a key stakeholder in the research enterprise. And as UNCST, there are a number of guidance documents that have been put out. But in the development processes of all these guidelines, we do engage our local researchers. So there is input that we do get from the local researchers in all the guidance documents that we publish or put out for use in the research enterprise. And they also have a number of networking opportunities that we do have. We have dissemination meetings, we have annual national research ethics conferences, we have scientific meetings, and all these opportunities that are put there to engage with the local researchers. Maybe what we are doing poorly, not only like you, the researchers, is on engaging the research participants. That is still a gap on our side as regulators, and I know we need to do more to engage the research participants, to teach them about their rights, their, what they can demand from the researchers. So that is still a gap, and I think as UNCST we need to do more on engaging the people that bear the burden of research. Thank you. Yeah.
Thank you so much, Winfred. We have time for one final question before we try to wrap up. And I can see Professor Sheena's hand is up. Go ahead.
Thank you. I'm Sheena McCormack from London. Daisy, will you indulge me just a moment to share some of the lessons learned over the years? And I really want to thank the panel and the organisers for arranging this. It's such a rich session. But it's in relation to some of the challenges when you do multi-country studies, because you're working across really quite different cultures. And going back to 2008, I was working with partners on a large vaginal gel study, and we were given help from the global campaign on microherbicides to organize a meeting where we brought community representatives, a participant, and the principal investigator from all of the participating countries to a meeting. And we were very sort of unsure of how that would work, because the experiences that were coming back through the feedback in social science and from community were quite mixed. But when we brought everybody together in the room where they could discuss things face to face, we realized actually there were common themes emerging. And as well as that, I think getting together gave them enormous empowerment. It really gave them confidence to see that these problems were shared. And I think that's so important. If you can put the money there as the sponsor, as the funder, to facilitate that type of gathering, it's really worth it. That was a very well-funded program. PrepVac has not been so well-funded, but the sponsor did find money to bring our community representatives to the meeting. So I kind of got a question for you, Father Emmanuel. Was that a good experience for you to meet the other community representatives from the other countries that are taking part in PrepVac? And then for Winifred, I wanted to just respond a little bit to your point, to your question about how we can engage people, because you can really engage the participants in meetings through participatory action research. You can't do that before the study because you haven't got any participants, but once you've got participants, you can do that, and that's a wonderful way to get feedback. So that was something I wanted to just share as well. Oh, sorry, Daisy, but I can't not thank AVAC for the GPP training that they provided for everybody in PrepVac at the beginning. That was really wonderful. And also to the point about the disinformation, the value of AVAC training all those journalists in prevention science, so that we had journalists who really understood the design of trials, the results, and were able to report them as independent monitors in countries. It's unbelievable, and thank you for that.
Yeah, thank you so much, Prof. Sheena. We will take the very last question, and then Father Emmanuel will respond in terms of the question, and then we're going to close the session. Thank you.
Thank you for the wonderful presentations that have been given. My question is directed to Manju and Nitha. My name is Ann Gunjeri. I work for LVCT Health. I primarily HIV Prevention Care and Treatment Organization based in Nairobi, Kenya, and my interest is in social science. And because we work in HIV, primarily we are funded by USG, and we appreciate all the hardships that came since the 24th. But we are stranded, or rather I am stranded, because as much as the stop work orders came, what followed was a ban of words that I felt have taken us way, way back. So I take pride in working in the Gender-Based Violence Prevention and Response Program. So keywords in all my documents are gender, gender-based violence, equity, adolescent girls and young women, and anything associated with the notion of not leaving anybody behind, marginalized populations. And we work with the transgender LGBTQ, and we appreciate why we work with them, because in any normal society, they are that cohort that are left behind. And we program towards making or giving them a fair chance at accessing services. And part of our research is on that. So I'm stuck at a point where, unfortunately, what Trump set, other nations are taking on. We are no longer working with gender equality. Where does that leave us as researchers? Where we are all about sustainable change and, again, not leaving anybody behind, making sure that everybody gets fair chance at accessing services, be it prevention, response, lifting the community. So if we are banned from using that, what does research uptake look like? What does community engagement look like? Because we also have to accept that it cannot be a one-size-fits-all, from the engagement in research to how they utilize this research, how we reach them, how we present our findings, to policy tables where we're just assuming a gender-blind approach. So what is your advice moving forward? Because a few other countries have already caught on, and they're like, we don't want to do this either. We want to shift our interests in other areas. Fair enough. But what does that mean for the communities where we work? Thank you.
Yeah, that is a topic for an entire session, and thank you for bringing it up. So I'll ask Nitha to give 1 minute and Manju 1 minute, but before that, we will hear from Father Emmanuel. Yeah,
my
thank you.
experience with attending a CAB member, I didn't think that there would be a moment, a person like me, a lay person in research, to be invited to say anything like this, to say something contributing to research. And I can say without any fear that now I can do. And I feel more confident. So I really thank MRC, Masakam and MRC, UVRI for this opportunity. It widens our understanding and our perception of things. When I went to South Africa with a team I think we are discussing PrepVac, and on coming back, I actually told Mr. Basajja, somebody else also needs to go and have a chance. And that's when they also looked at Oliver, who is also being empowered. How I wish even other members can do, but we need to continue reaching out to other people, empowering other people. The knowledge I get doesn't stop on me. The coordinator of medical service in the diocese. If you could come to our forum, you don't have the permission, but I always share information about research, about health, and some people even go to my inbox and inquire more about more what I have posted. Like recently, they talked about, we had a meeting on the new vaccine for malaria, but the responses I got were very, very positive. People could go in the box and inquire more and more about how that research was conducted. Well, I can say 90% of the priests didn't know there was a vaccine for malaria until I shared on the forum, and even I shared documents. Yeah, I think, I don't know whether I'm answering the question, but that is my take.
Go for it, Nita.
So I'll meet you after the break, after the session, but two quick things. One of the things we must never forget as individuals, researchers, CAB members, that the money or the funding does not necessarily equal to our local regulatory guidelines and our ethics committee's guidelines regarding the language we use and the community engagement program. So that does not change because we comply, we adhere from a regulatory point of view what's local. If I'm getting money from a group that speaks to the specific language issue, I need to ensure, though, that I meet country requirements, community requirements, affirm what language I'm using with my ethics committee and my regulators, and then submit those documents. The last point is that there's an equity language guideline that came out last year, just before this changes, and we were all working towards language that was with equity, that was inclusive, and ensure that it is accepted by our community engagement program. And so we're going ahead with that because it's locally driven. But we can chat more about it after the discussion. Thank you for those questions.
Manju, 1 or half a minute.
Yes. It's a travesty, truly, to have to censor our language and roll back all the work that we have done collectively in global health development, to be forced not to talk about the importance of equity, of inclusion, and of having diverse populations. And I know from a civil society perspective, we are really considering this, and of course, as advocates, we are pushing back. We are unified in pushing back. And the different strategies that we're thinking about is really talking about cost effectiveness, because that's the language of policymakers as well, about how inclusivity is cost effective in making sure public health impact is impactful, in leveraging data about evidence about how funds are wasted if we are disregarding community members who we have acknowledged and have researched that have more needs. Importantly, I think that there have been organizations or movements that have always struggled with this. And if you think about reproductive rights, who don't receive a lot of US money specifically because they talk about reproductive choice, I think there are allies there to really band with, to understand how they have navigated this political landscape, because they've been dealing with it for a long time in not being able to talk about reproductive choice with certain communities. And I think we need to sustain pressure on the non-USG funders to fill the gap, to see what will happen if we aren't allowed to be inclusive in our research. All the gains we've made, we will lose them. And I really think that any funders who call them, who have said their mission is to really be engaged in global health development have to step up at the same time that we are pressuring the US government on not censoring really importance of, and of course, I will tell you, a lot of organizations are finding ways around it, are talking about equity and inclusiveness, but just not using those words, but really talking about the essence of involving all members of the communities to ensure that everyone who HIV affects is included. So I think there are some interesting tactics to learn from civil society in navigating this process.
Yeah, thank you so much, Manju. We are about to close the session, and I will actually request one final word from Flavia, and then we are going to wrap it up because time is not on our side. Thank you.
Okay. Thank you, Daisy, and thank you all the panelists for that beautiful engagement. I think the message is clear. We need to meet the standards. We need to be deliberate about our community engagement, consult, but also receive feedback from the community, build the evidence, the partnerships, so we can influence the policy agenda. Thank you.
Thank you all for your sharing your lessons, and I want to learn more from you. So I think we need to learn, unlearn, and relearn. We need to drop our egos and position and power. And very importantly is that we need to be authentic in the work that we do. Speaking the truth, we have seen that with AVAC, we've seen that with groups in South Africa, we've seen that with my own president, who said that while we're in a difficult situation, there's actually opportunity for us to work together. And then the last thing I want to say is that from a last word point of view, I observed excellent skills in posters yesterday, and I really think that we need to collaborate more effectively with action from a south to south point of view. Thank you.
Yeah, thank you. For me, my parting words would be, in terms of funding to research, do we need to reinvent new partnerships? Then if we have joint collaborations, like here we have MRC, UVRI, London School of Hygiene, can we improve these? Can we work with what we have? On day one, Dr. Okware mentioned that this is a marriage of three. Can we improve these marriages that we have as collaborators just to work towards research? Then last but not least, community engagement is key. Most of the forums you go to, researchers will talk about community engagement, but are we walking the talk? How are we engaging our communities? Is it an ongoing process? When are we starting to engage? Who are we engaging? What languages are we using to engage? So we need to engage effectively such that we have research that is responsive to the needs of our communities. Thank you.
Yeah, my last word would be to thank MRC and UVRI for inviting us and for involving us in this noble duty of doing research. We are very, very, very grateful. Thank you for the empowerment. We feel empowered. How I wish we continue supporting the community. We need to invest more in the community. Can we think of increasing the budget for community engagement? That is a key element that needs to be looked at. We need to involve more the media those are very key stakeholders. We could really educate them, they are able to pass on the information, and other groups within the different constituencies that are being engaged. I thank you for listening to me.
Thank you, and really just building off what my fellow panelists have said, that the power of true collaboration is integral, and not only when there's a crisis or a problem, but ongoing. And that especially relates to the engagement of community members. Community members and civil society need to be at the table when research is being dreamed up, when a new idea is being even conceptualized, so that it is designed in a way that really has civil society thinking about the national impact and the rollout, and community members really thinking about how it will affect their day-to-day lives. And we need community representatives at the table, not only as beneficiaries of research, but in shaping the research agenda going forward.
Thank you so much, Manju. And I have very little to add apart from very sincere thanks on behalf of the panel. I myself have learned a lot from how ethical boundaries can be crossed, to the importance of listening to communities. Start with a prayer if this is the culture. Otherwise, that's going to be the thing that's remembered and not what you have been talking to the community. And go beyond the cabs. Root out disinformation, and we can also be influencers. Father Emmanuel actually shared with us that during the COVID pandemic, he took the vaccination and actually posted it on social media. And so that is like an influencer right there. So, but I think a lot of us are shy. Inclusion. Start early and continue. And it's not a destination, it's always a journey, and we are always on this journey of community engagement. And I think with actual, true, and strong community engagement, we can really harvest more than even we sowed in the first place. Thank you so much for your attention, and we will close the session and wish you a good evening ahead. Thank you.
It is on, yes, great. Thank you so much to all the panelists. That was an absolutely fascinating discussion, and it's really challenged me to think very carefully about my work around community engagement, and I have a lot to learn, so thank you so much for that. And on that basis, that was the last session for the day. Thank you all for all your contributions. We have the poster session now, as we did yesterday. If you are an adjudicator, please again go out to the right, where you will get your boards and so on, your scoring sheets and so on, and then we'll have a cocktail. It's in a different location today, but you will be guided to the cocktail. So last thing again, just to thank everyone sincerely for all your participation, and particularly to everyone behind me. Apologies for talking to my back. All right, thanks very much. Bye-bye.